Welcome to the December P&T meeting. Um, if you're in the audience, if you have the opportunity, please enter your full name and your affiliation so we can accurately capture that for the record. We're going to go and start with our roll call and introductions. So, Pat, can you lead us off?
Everybody, Pat Martino, I'm a pediatrician and faculty up at OHSU.
Welcome, Pat. Kat?
Pat Livingston, Medical Director of Health Share of Oregon, also a family physician at OHSU.
Welcome, Kat. Stacy?
Hey everyone, Stacy Ramirez, faculty at Oregon State University and Chief Clinical Officer for Preventa Health.
Welcome, Stacy. Tim?
Yeah, Tim Langford. I am the pharmacy director with the Klamath Tribes.
Welcome. And Bridget?
Hi, I'm Bridget. I'm a clinical pharmacist in mental health at Kaiser Northwest.
Welcome, Bridget. And we'll turn it over to Samara.
Hi, I'm Samara. I am a naturopathic physician that works with mental health and metabolism in Portland.
Welcome. Jeannie wasn't able to join us today, so Doug, we'll turn to you.
I'm Douglas Carr. I'm an internal medicine physician and medical director at Umpqua Health in Roseburg.
Welcome. And Russ is planning to join. He's going to be a little late, conflicting meeting right now. I also expect to see Dr. Onishi. And Eddie wasn't able to join us. So as they come in, I'll try to fold them in and shuffle them in as we introduce staff. So let's turn it over. I didn't see Jennifer. Are you on, Jennifer? Not. So I'm Roger Citron. I'm the pharmacist director of the Drug Use Research and Management team, and we provide the clinical support to the OHA.
Hi, everybody. I'm Trevor Douglas. I am the Pharmacy Policy and Programs Director at the Oregon Health Authority.
Good afternoon. I'm Dave Engen, a clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the P&T clinical coordinators with the Derm team.
Hello, I'm Andrew Gibler. I'm the clinical pharmacy manager at OHA and also have a small faculty appointment with the Derm team.
Hi there. My name is Kyle Hamilton. I'm the pharmacy drug coordinator at the Oregon Health Authority.
No Dan Hartung to join us, nor Megan, so Deanna will turn to you.
Hello, I'm Deanna Moretz, pharmacist with the Derm team and OSU.
Great, I'm Kathy Centena, and I am a pharmacist as well with the OSU Derm team.
Hi, my name is Sarah Serwood. I'm a clinical pharmacist and P&T clinical coordinator with the Derm Group.
I am Lance Starkweather, pharmacy manager for Gainwell Technologies.
Dee is wearing one of her many other hats today, so will not be joining us. So Brandon, up to you.
Good afternoon. My name is Brandon Wells. I am the pharmacy program and operations analyst for the fee-for-service program at OHA.
Ted as well will not be on this call. Did we see Michael join or no? I didn't see him. So Michael, you, valuable member of Trevor's team, isn't here, but he's here in thought. So with that, as I see others come in, again, we'll interrupt just to have their recognition. Conflict of interest declaration. So it's very vitally important for the OHA to have conflicts of interest disclosed. All of the staff, the Derm team, as well as all the P&T committee members have conflict of interest declarations on file with the OHA. We do this annually. We also have anybody that's wishing to provide public comment fill out our short conflict of interest declarations so that can be disclosed to the committee so they're aware of any conflicts that might be aware. But at this time, we'll leave it open to the floor. If the committee members have any recent conflicts that have arisen that they needed to disclose to the rest of the committee and to the OHA. Didn't anticipate any, but still wanted to have that moment just to acknowledge that. Next, we have the approval of the agenda and minutes. The minutes from the October P&T meeting were sent to the committee in advance. They had a chance to review. If you're following along in the packet of materials that we have posted to our website where you found the login information for this meeting, I'll call out different pages. So we'll be on page 4 and open it up to the committee to see if you have any edits that need to be made to those minutes. And if not, I'm going to hold on for 1 second. We have a committee member joining us. Russ, going to put you on the spot. Are you able to unmute your line?
Yep, seems so.
All right. We just went through introductions. Can you briefly introduce yourself?
Oh, hello. I'm Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Appreciate your being able to join, and I know you're multitasking, so thank you. We just asked if there were any conflicts. I assume you don't, but I'll ask if you have any new conflicts you need to disclose.
No conflict.
Excellent. Next, we were talking about the minutes that were sent out in advance. They're page 4 in the packet of materials. So we're entertaining a motion to approve the minutes.
Motion to approve.
Appreciate it, Doug.
Second.
Thanks, Maura.
All right. All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right. Thank you.
Great. And I'm going to go off video. It's distracting me to look at my handlebar mustache. So with that, we have Trevor Douglas with us, who's going to provide the department update.
Hi, everybody. Thank you very, very much for your time and dedication to the P&T work today, and as always. Next slide, please. I want to cover some important things that are relevant to today's meeting and just for awareness for everybody. And then also make sure I reserve some time to express my gratitude and recognize the leadership of some of you on the committee. So first off, I kind of want to cover sickle cell therapies and organs participation in an access model, and then talk a little bit about the high-cost drug carve-out that is happening. And with that, let's go to the next slide. So Oregon is entering the implementation phase of the Center for Medicare and Medicaid Innovations Cell and Gene Therapy Access Model. This model is set to begin January 1st of next year, and it will involve 2 gene therapies on the market for sickle cell disease. And I'm going to murder the names, but I'll say them anyways. Lyfgenia and Casgevy. I might have got brownie points from all my pharmacists for getting it right, maybe. Next slide. We had originally intended to implement the CMMI program focused on both drugs concurrently. However, we have recently learned that, unfortunately, Casgevy will probably not be available in Oregon by the start of the year. And because Oregon Medicaid rules generally require members to receive care from in-state providers whenever possible and clinically appropriate, we will be starting the model with our focus on Lyfgenia. The other thing that I want to be clear is that there still will be a pathway to coverage for Casgevy. But until Casgevy is available from an authorized treatment center within Oregon that participates in the CMMI access model, prior authorization will be required for Casgevy. That prior authorization would need to document why Lyfgenia is not clinically appropriate before coverage would be approved. All right, next slide, please. So just moving forward into this next year, we're also seeing the implementation of expanding what drugs are carved out of CCOs. This means that there'll be additional drugs that will be reimbursed on the fee-for-service side for all Oregon Health Plan members. And this new program is called the High Cost Drug Carve-Out, or the HCDCO. And next slide. The drugs included in this new carve-out will are generally estimated to cost more than $500,000 per patient per year, and are indicated for rare conditions or in instances where there's few or no alternative treatment options. And you'll be hearing a lot more about the details of this program and the drugs included on this list later in the meeting. All right. So next I have the privilege of just acknowledging a few folks, and want to state how fortunate we feel to have been able to be served by Dr. DiMartino and Dr. Ramirez, and their willingness to reapply and now be reappointed to new terms. But unfortunately, we are having to say goodbye to, but not really, because she's still going to stick around, Dr. Livingston. So I want to first just recognize our chair, Dr. Stacy Ramirez. She is a true trailblazer in the pharmacy profession. I mean, she's so much a passionate advocate for community health, and has demonstrated that by having over 2 decades of experience in community pharmacy. Dr. Ramirez has also dedicated her career to improving health outcomes for underserved populations, and continues to be a mentor and plays a very important role in the development of the pharmacy profession as a clinical assistant professor at OSU College of Pharmacy. And just personally, Stacy, you just exemplify compassion, innovation, and excellence in the pharmacy profession, and we're so lucky to have you. Thank you. Next, I want to recognize Dr. Pat DiMartino. We appreciate his outstanding service and steadfast commitment to our work here at the Pharmacy and Therapeutics Committee. And we recognize his work as an assistant professor of pediatrics at OHSU and the specialist roles that he serves at Dornbeckers, taking care of children with complex blood disorders and those undergoing bone marrow transplants. We appreciate your expertise, both clinically and your knowledge of the economics of emerging therapies that you have brought to the committee and Oregon's drug policy work. And on a personal note, Pat, I'm grateful for your continued leadership and dedication in improving the lives of some of the most health-affected children in our state. Next slide.
Thanks, Trevor.
Yeah, you're welcome. Thank you. Next, I have the privilege of saying a few words about a colleague. I want to take a moment to just recognize Dr. Kat Livingston and her exceptional service to Oregon, the Oregon Pharmacy Therapeutics Committee, and just all of the contributions that you have made to date that will continue to, and I know there will continue to be contributions, but even with the contributions that you've made to date, they will have lasting impacts to our the health policy in our state. Interestingly, Dr. Livingston and I both joined OHA around 2010, and from the start, I benefited from Dr. Livingston's mentorship and collaborative spirit, and her ability to challenge me and others to grow both as a clinician and a policy thinker. I appreciate your clarity and your integrity and your deep commitment to evidence-based care that have shaped not only the work of this committee and others that you have been involved with, but also the broader direction of the health system, as I already mentioned. I know you'll be stepping away from the P&T committee, but we're really fortunate that you'll continue to serve Oregon as a member of the Evidence-Based Guidelines Subcommittee on the HERC, where you served as our medical director at one point in time. On a personal note, Kat, you're a powerful advocate for thoughtful, patient-centered, and evidence-based policy. And your leadership will continue to leave that lasting mark that I described. And thank you for your mentorship over the years. I hope it's not over. And for your leadership and your continued dedication to improving the health of all Oregonians. So thank you, Kat, for your time here on P&T. With that, I will move on.
One set, I just wanted to also extend my appreciation, Kat. You'll be missed on the committee, but continued work with you through HERC. So thank you for all you've done. It's Yeah, been an absolute pleasure and appreciate everything. I also wanted to take a moment. Dr. Eriko Nishi joined us, so I just wanted to let her introduce herself to round out the P&T committee.
Hi, I'm Eriko Onishi from OHSU Family Medicine.
Great. I just
Physician.
wanted to, yeah,
Thank you.
welcome. I'm glad you could join us. Just to acquaint you, we were just announcing that Stacy and Pat on the committee, their terms are ending, but they have thrown their hat in the ring to be reappointed and were reappointed. But Kat Livingston's term is ending, and she is elected to not be looking for reappointment. So we're looking for we have a new physician that we'll be appointing next year, but we're just extending our gratitude to her service. And Kat, I jumped in. I didn't know if there's anything you wish to say, but greatly appreciated.
Oh, thank you. It's been such an honor for all these years to work with you, and you are stuck with me for a lot longer in other fora, but just really appreciated the recognition and our long-term professional working relationship and all the evidence-based policy making we've done together.
Thank you so very much. Trevor, back to you.
That's all I had today, unless you want me to make something up.
Please, no. So we're going to turn it over to Andrew Gibler. Give us a little update for the Mental Health Clinical Advisory Group.
Thank you, Roger. The Mental Health Clinical Advisory Group continues to work on treatment guidance for ADHD in adults, including guidance around how to diagnose that population. I would like to announce a few openings. There's some openings on the website, but in short, we have a retirement. Someone is retiring. That represents the CCO, and so we will have CCO representation needed on the group, and so that will be available beginning in March. And we also have some seats that are expiring, a pharmacist and a healthcare or mental health advocacy organization representation. And both those, I know the pharmacist is seeking reappointment, but anyway, those are all open for anyone to apply if they're interested and qualify for those seats. And with that, Roger, I'm going to give it back to you.
Appreciate it, Andrew. Any questions from the committee for Andrew or the Mental Health Clinical Advisory Group? All right, hearing none. We have a standing section in our meetings every other month. It's our consent agenda. As you're aware, and I mentioned at the top of the order, this P&T committee also serves as our DUR board. So we focus efforts once meeting per quarter on DUR activities. So we have our quarterly utilization report that is run quarterly and printed and then posted to our website. So that's part of this. That's publicly available. And then we also have our standing oncology and orphan drug policies, to which we add new agents as they come to market, so we can preserve some of the bandwidth of the P&T committee, add those agents to apply the standing criteria. So with that, we need a motion from the committee to approve the additions as part of the consent agenda.
Do we have a motion?
Motion to approve.
I'll second.
Thank you. All those in favor?
Aye.
Aye. Aye.
Aye.
Opposed? Oh, thanks. Opposed? Abstain? Right, thank you.
Great. So the first component of DUR is prospective DUR that happens at the point of sale. We have a report run by Gainwell. So we have Lance Starkweather with us to go over the report. And if you're following along in the packet of materials on the website, it starts on page 29.
Thank you, Roger. So what we have here is a high-level summary of the 11 prospective alerts that are set to the system. The highlighted rows, again, most of these are informational. The highlighted rows are the ones where the claims will deny and require a pharmacist intervention. So the early refill and the pregnancy drug interaction. This is for the third quarter. We're talking about July through September of 25. Pretty standard compared to previous quarters. just a little bit higher on the early refill, so 115,000.
Lan,
The percent. Yes.
sorry to interrupt. You're just fading out a little bit for my old ears. If you're able to turn up your microphone just a tad bit, please.
Okay, I will try to do that.
Oh, that's
that
good.
better?
Much better. Thank you.
Okay. Yes, so for the early refills, 24% of the claims that hit that alert were overridden. And then for pregnancy drug interaction, 44% of those claims were overridden. Next page. Here are the top drugs that are enforced in the early refill alerts. Primarily, we're looking at the carve-out and the anti-seizure medication, lamotrigine and divalproex. The first category I have is the SSRIs. About 22% of those prescriptions are overridden. Next, it's the other antidepressants. About 1 in 4 prescriptions of those are overridden. Similar statistics for the antipsychotics as well. And then for the benzodiazepines, those ones typically have a higher percent of overrides, about 38%. Next page. Here is the summary of the different submission clarification codes on the early refills. A majority of them will be submitted with a submission clarification code of 7, which indicates that it's medically necessary on why they need the medication early. 11% due to a change in therapy, and then 4% is due to a lost medication. And then lastly is the cost savings from the early refill. So this is when the alert hits the system, but then the prescription is not filled as a result of that. So we count that as a cost savings. For July 93% or 93 prescriptions were not filled. That's 37,000 cost savings to the state. August had the most. This is probably due to people trying to get medications early for just some vacations, and then the pharmacy just ended up not filling it at all, or so we had 560 prescriptions that were not filled, so 169,000 total. And then for the month of September, 88 prescriptions not filled. Total cost savings for that month is 20,000. Overall for the quarter, 227,000. Any questions on the prospective DUR?
Hey, Lan, sorry, I think I probably asked this like every other time, but just to make sure. So why are the August totals so much higher than the other 2 months? Is it just the way that the weeks fall or the data is collected?
Yeah.
Okay, that's what I thought. I'll try and remember for the next time.
Any other questions for Lan? All right, thanks, Lan. The next component of drug use review is retrospective, and we take care of that, have some reporting done. So if you're following the packet, let's turn your attention to page 33, and Dave Engen takes the lead for us. So Dave, I'll turn it over to you.
Okay, thank you, Roger. So yeah, the document on your screen, it's the most recent version of the report, which may differ slightly if you have an earlier version of the packet. But it presents a quarterly data on the different drug use interventions and outcomes for quarter 4. So that's July through September of 2025. So on this page is Billing Correction Review Initiative. We're keeping track of the high dollar claims that may have been billed incorrectly for just the different patients that might have other coverage. It appears that we're able to review more of these claims in quarter 4 compared to quarter 3. When we find these incorrect billings, the pharmacy is asked to process the claim or the claims, and then we can enter the savings manually. So we'll keep you posted on our progress as we find the incorrectly billed claims. On page 34, this is our alert for providers for them to consider change to a more cost-effective formulation. And it's automated and it tracks cumulative savings. And this one in particular continues to generate modest savings for the aripiprazole tabs. But there's still quite a bit of desvenlafaxine agents, savings for those agents as it runs in the background. So we're going to keep that one going. Yeah, page 35. This captures the letters going out to the providers for dose consolidation, and now with it being point of sale, there's nothing to report currently. Page 36. This is our expert consultation referral for long-term antipsychotic use in kids. There's lots of patients that are screened. There were 7 flagged as high risk, and each of their providers received a referral to OPAL-K for a consult. And most of those patients continued with their therapy. So page 37, this is our messaging to prescribers about patient non-adherence to their antipsychotics. And the total patients identified, it appeared to have increased. In quarter 4, there were 70 prescribers identified and notified, and half the patients got a refill for their medication within the next 90 days after the prescriber was alerted. So on the right track there. Page 38 lists the different individualized profile reviews that are performed for children in foster care, as well as for patients with a variety of high-risk conditions, so bipolar, polypharmacy, chronic opioids, and those types of things. So these are staying fairly consistent each quarter, and we continue to send out alerts and recommendations that are customized whenever it's appropriate. Yeah, so on page 39, that's our safety net program for antipsychotics in really young children. Of the 17 providers, looks like we're able to notify 14 to submit a new PA for their patient before it expires, and want to avoid interruptions in care. It looks like almost all the patients of those prescribers were able to get a paid claim in the following months. So that's good. And lastly, on page 40, we report safety net monitoring. The first one's for patients on dangerous opioid sedative combos. Roughly half of those prescription combos are being discontinued within 3 months after notification. There are also new naloxone prescriptions that are going out along with that. So that's good. You can also see there were no oncology med denials that were flagged in quarter 4. And then with the pediatric patients on TCA, so there were 6 that were flagged as having been denied a TCA, but no alternative was filled or requested. And 3 of those prescribers were notified, and 1 patient ended up with a paid claim for a TCA. So, yeah, so moving right along, and that's just a quick summary of the Retrodur report. As always, if you think of new opportunities, please let us know, and we'll investigate it further and get back to you on that. But for now, if there's no other questions, I'll just turn it back over to Roger.
Thank you, Dave. Any questions from the committee for Dave on our Retrodur initiatives? Great. The next component of DUR activities is a requirement for education of providers. And one of the ways that we accomplish this is through the Oregon State Drug Reviews. There are newsletters, and we'll turn it over to Kathy Centena, our editor.
Great, thanks, Roger. Yeah, so today we'll be recapping 3 newsletters. The first one was in March of 2025. We published a newsletter on the role of the Mental Health Clinical Advisory Group, including summaries and links to the clinical practice recommendations that have been developed by the group. The next newsletter was published in April of 2025, and it was on the pharmacotherapeutic options for treating adolescents with opioid use disorder. This newsletter included reviews on OUD management guidelines, as well as studies supporting the recommendations and the policies from OHP for OUD treatment in this population. The third newsletter, published in June of 2025, was on medication safety. This newsletter touched on new safety warnings, changes to drug labeling, and risks to obtaining medications online. Again, we appreciate the authors so much who help provide these important provider education pieces, and to the committee as well for providing feedback and suggestions. A reminder that you can always get our newsletters. You can just sign up on our website to receive them electronically. And I encourage you to take a look at our recently posted newsletter on RSV prevention. I'd also like to solicit any newsletter topics from the committee that you think might be of interest to our providers. And you can always email those to us as well if you think of them after the meeting or any time, really. We love to get those.
I just recent came on JAMA about the vaccine, which decreased the dementia. I don't know if it's too new, but I thought it was very interesting.
Interesting.
Yeah, thank you. Okay.
We'll take a look at that. Thanks, Dr. Nishi. Again, if any thoughts come up about other topics like Dr. Nishi just shared, let us know and we can consider that, see if it lends itself towards one of our newsletters in our audience. So thank you, Kathy. Now we're going to start into some of the new business. So again, if you're following along in the pack of the materials, we'll be starting on page 50 for the antifungals class update. Kathy, going to leave it in your hands. So I'm going to go back on mute.
Great, sounds good. So the evidence for the use of topical oral and vaginal antifungals was reviewed by the committee back in 2023. So the purpose of this update is just to evaluate any new comparative evidence that's been published since that last review. Just a quick review, quick background review on antifungals. Of course, the antifungal choice depends on the indication, causative organism, and resistance patterns. As we all know, fungal infections are commonly caused by yeast, which are unicellular, but also less commonly caused by molds, which are filamentous, which impacts what therapies we use or recommended. Oral fluconazole is most commonly recommended first line for the majority of the fungal infections due to its efficacy, and it's very well tolerated. The preferred antifungals are listed there for the oral preparations as well as the topicals and vaginals. And just as a reminder, the OHP does not fund the treatment of candidiasis of the mouth, skin, nails, or dermatosis of the nail, groin, or scalp, or other types in immune-competent patients. Now, those that qualify under the EPSD program can be evaluated by a case-by-case basis to get these diagnoses covered. So for most of the utilization for antifungals was for preferred agents, as you can see there. And the literature search that was done identified 1 new guideline, 1 new indication, and then 6 antifungal safety updates. The new guideline that was identified was the National Institutes of Health updated guidance on the prevention and treatment of opportunistic infections in adults and adolescents with HIV. Now, these recommendations align with our current policy for the coverage of antifungals for patients who are immunocompromised. I encourage you to look in the packet. It starts on page 53. There's a detailed review of this guideline if you're interested that provides a lot more information. For new indications, the first one, first and only, is for Cresemba, for its generic name isobuconazonium. And it is indicated as an injection for pediatrics that were 1 year of age and older back in December of 2023 for the treatment of invasive aspergillosis and invasive mucormycosis, or so IA or IM. And then the oral form of that also was approved in the 74.5 milligram strength and the 186 milligram strength for those that were ages 6 years of age or older and that weighed at least 16 kilograms. Now, the evidence used for approval for this was just one small trial in pediatric patients. It was a phase 2 open label non-comparative study that in patients that were 1 years of age or older to less than 18 years of age that had probable or definitive IA or IM. The primary endpoint was all-cause mortality at day 42, which was reached by 6.5% of the population. However, successful response rates were reported in 54.8% of the population. For safety updates, there's 3 for itraconazole. The first one is a warning with a risk of pseudoaldosteronism characterized by new onset of hypertension and abnormal lab values. They do recommend that blood pressure and potassium levels be monitored to identify these patients. The second one is a precaution for drug interactions with itraconazole. As we know, it is metabolized by the 3A4 enzyme system, and so there's some new interactions that have been posted. And then the last one, just post-marketing reports of bradycardia also noted with itraconazole. From, metronidazole, there has been a noting of a risk of severe cutaneous adverse reactions or scars and hearing impairment. So patients should be monitored for these. And then for posaconazole, there's a warning also of a risk of pseudoaldosteronism. So additional labs should be taken and advised if suspected. And then lastly, for voriconazole, there is a contraindication for its use with finerenone because it can increase drug levels of finerenone and exposure and increase risk of serious adverse events. So those should be avoided. Next, we're going to talk about the PA criteria a little bit. There's actually been no changes other than the tables on covered and non-covered indications has been updated with just minor updates and just that those diagnoses have been verified. So we can go through it in depth if you'd like, but I would suggest perhaps that unless you see something specific you want to talk about, we just go ahead and keep going with the recommendations. You can see that it's quite lengthy as well. So the recommendations for this class, no changes to the fee-for-service PDL for the antifungal drug class, and then to evaluate drug costs in executive session.
Great, Kathy. Any questions for Kathy?
Hey, Kathy, it's Stacy. It's not a question, but I had a thought about a newsletter idea. What about the new hypertension guidelines?
Yeah, that would be a great topic. Thank you.
Welcome.
And again, at this point, no changes are being recommended to the preferred drug list or the, so we're just going to be reviewing those in executive sessions. No need to take a vote at this point. And no additional questions. We will forge ahead. Thank you, Kathy. Next, we're going to turn your attention to page 73 in the packet of materials, and we'll turn it over to Sarah Servit.
Thank you. And before I get into the topic of epidermolysis bullosa, I'm going to give an overview of the policy that Trevor touched on briefly in the department update. This is our new high-cost drug carve-out list. And so the purpose of this new list is really to mitigate risk for some of our CCOs related to very high-cost drugs for rare conditions. And so the drugs on this list that have been selected for this list are estimated to cost over $500,000 per year and are really for those rare indications where there's few alternative treatment options and where CCOs have not very many utilization management tools that they can employ. After reviewing requests submitted by the CCOs, the OHA has identified about 47, maybe 48 drugs that are going to be on this list starting at the start of the year. A lot of these are one-time gene therapies that cost over $1 million for treatment. There are some chronic therapies that are also on this list. In particular, drugs for lysosomal storage disorders and drugs for Duchenne's muscular dystrophy are examples of some of those chronic therapies. There are others, and this list is going to be finalized and posted hopefully later this month to the pharmacy policy page. So we've got implementation planned for the start of this year, and the way that this high-cost drug carve-out is going to work is that the drug itself will be paid for by fee-for-service for all OHP members, whether they're in a CCO or not. But the CCO will still be responsible for all of the other associated services, so supportive care, administration of the drug, any additional therapies that are needed, and coordination are all going to be provided by the CCO. As part of this process, we are also formalizing a process for secondary medical director review of PA requests for these very expensive drugs. So you will see that in some of our PA criteria. And there are opportunities to make changes and additions to this list. So as part of implementation, we have a process for getting requests from CCOs about things to add or remove or change to the list. And then we also have an internal process for monitoring new drugs for rare conditions that might meet this criteria and adding them to the list. So what this means for the P&T committee, you'll probably be seeing more drug reviews for some of these rare conditions. These are generally drugs that we've typically added to the orphan drug list, and the plan still is to add some of these drugs to our orphan drug PA criteria. But we'll probably do reviews of some of the drugs that are more common where we might expect more utilization. We are going to try and streamline these reviews to still continue to provide a comprehensive review of the evidence, but really focus in on those points that are needed for you all to develop evidence-based utilization controls. So I'll pause there. Any questions about this new high-cost drug carve-out list? Okay,
You explained it well. Good job.
Yeah, hearing none, I'll jump into our first topic. We've got several on this agenda that do fall into this category that we're reviewing that are on this high-cost drug carve-out list. And these 3 drugs for epidermolysis bullosa are all on the list. So as background, epidermolysis bullosa is a condition that affects skin integrity and can cause chronic non-healing wounds. There are several subcategories based on the genetic deficiency and where blisters form on the skin. So the 4 main categories are epidermolysis bullosa simplex, which is generally a more mild form of the disease, Kindler epidermolysis bullosa, which can be more severe, in which blisters can form in any layer of the skin, junctional epidermolysis bullosa, and then dystrophic epidermolysis bullosa. And dystrophic can be classified into 2 subgroups based on the inheritance pattern of the gene as either autosomal dominant or recessive. And these last 2 types are where we're going to be focusing most of our time today because we've got drugs that are indicated for junctional and dystrophic epidermolysis bullosa. So Birch tritopines has an indication for both junctional and dystrophic epidermolysis bullosa. A topical gene therapy, Burimagine Geperpavec, is indicated for both forms of dystrophic epidermolysis bullosa. And then A second gene therapy, prademagene zamikeracel, is indicated for the recessive type of dystrophic epidermolysis bullosa. So before these treatments were approved by the FDA, treatment was primarily supportive. So standard of care typically includes management for pain in these wounds, management of itching, because healing skin often is associated with that pruritus, and then also wound dressings that are specific to the type of wound. So depending on whether you need exudate management or to soften the skin. So the wound dressings are typically selected based on the wound characteristics. Because this is a rare condition, most of the evidence for specific topical medications is based on case reports and expert opinion. And over a 1-year period, from April 24 to March of 25, we identified 7 OHP members that had a diagnosis of dystrophic epidermolysis bullosa in their medical claims. So we're not talking about a huge population of people here. A little bit more about the treatments. Birch triterpenes decreases inflammation and promotes wound healing. That's how it's supposed to work. It is applied with dressing changes every 1 to 4 days and is available as single-use sterile tubes. It's estimated to cost a little over $500,000 per day with daily administration. Beremagene gepervovec is a gene therapy that delivers a functional COL7A1 gene to cells, and so that's the gene that's deficient in dystrophic epidermolysis bullosa. It doesn't incorporate that gene into the DNA of the patient's cells, and so it does have to be reapplied topically every week. It's estimated to cost a little over $1 million per year. And then prademagene zamikeracel is another gene therapy in which the patient's cells are collected from a skin biopsy. They're modified and then resewn on during surgery. And so in theory, they will continue to produce that functional COL7A1 gene long term. And it is estimated to cost a little over $3 million per treatment. So evidence for these drugs was based on primarily a single randomized control trial for each of them. Birch triterpenes was approved based on a double-blind, placebo-controlled randomized trial. They primarily studied recessive dystrophic epidermolysis bullosa, but other populations, including junctional and dominant dystrophic EB, were included. This trial had the largest number of patients, a little over 200 people randomized. They studied treatment over a duration of 45 days, so it was the shortest trial out of all of these 3 drugs. Major inclusion criteria, they included people with partial thickness wounds that had lasted at least 21 days and weren't older than 9 months, and wounds that were between 10 and 50 centimeters squared. The median wound size was about 15 centimeters squared. They did exclude people with history of basal or squamous cell carcinoma in the treated wound, people with infection in the treated wound, and people on immunosuppressive medications, and that was standard across some of these trials. Beremagene gepervovec was studied in an intra-patient randomized control trial. So in this study, as well as the prademagene zamikeracel, both patients had to have matching wounds of similar size, location, and appearance. One wound was treated and the other one wasn't. And so then they were able to compare wound healing in the treated versus the non-treated wounds. In this study, median wound size was 10 centimeters squared. 31 people were included, and they had similar exclusion criteria, so excluding people with a history of squamous cell carcinoma, infection, or people that were on immunosuppressive medications. And they studied treatment over a little bit longer duration of 24 weeks. Prademagene zamikeracel was an open label study because of the design or the application of this drug having to be sewn on during surgery. Blinding wasn't possible in this trial, so they still had matching wounds, one that was treated, one that wasn't, but people knew which wound had been treated. And they enrolled only 11 patients, but all of the wounds in this study were generally larger than the other two studies. So wounds had to be over 20 centimeters squared and have been an open wound for more than 6 months. And here you see the efficacy results for the primary outcomes that were specified in these trials. Birch tritropines evaluated complete wound healing at 45 days. In the treatment arm, which is the first group here, 41% of patients had complete wound healing compared to almost 29% in the placebo group. Their secondary outcomes, including time to first completed wound closure and complete wound closure at 90 days, weren't different between groups. For Burimagine Japervovec, they evaluated complete wound healing at 24 weeks. And again, treatment was better than placebo, with 65% of people having complete wound healing in the treatment group compared to 26% in the placebo group, with similar outcomes also at 12 weeks. That was one of their secondary outcomes. Prademagene zamikeracel evaluated wounds that had healed by at least 50% at 24 weeks for one of their primary outcomes. And these were generally much larger wounds than the other two studies. And people that had treatment had 81% of wounds were at least 50% healed by 24 weeks compared to 16% of wounds that didn't get treatment. So a treatment difference of 67% there. They also evaluated pain reduction at 24 weeks, with more pain reduction in the treatment group compared to the placebo group as one of their primary outcomes. As a secondary outcome, they did evaluate complete wound healing, which is maybe a more clinically relevant outcome than 50% of wound healing, with improvement in the treatment group compared to the non-treated wounds. So 14% of treated wounds had complete wound healing at 12 weeks compared to none in the non-treated group, and with similar outcomes at 24 weeks as well. So all three therapies were generally well tolerated in short-term studies. Local application site reactions were some of the most common adverse events in the Prademagene zamikeracel group. The most common adverse event was procedural pain, because it does require surgery for application. Serious side effects were generally infrequent. The gene therapies, the intrapatient design of the trials did confound the systemic safety evaluation. Every patient for these gene therapy studies received treatment. There weren't any placebo patients, so makes evaluation of systemic safety a little bit more difficult. Lifelong monitoring is recommended for the Prademagene zamikeracel because of the potential for retroviral vector-mediated insertional oncogenesis. Some of the major study limitations for the Birch tritropine study, there was high risk of bias due to differential attrition and differences in baseline characteristics between the groups. And in a subgroup of people with junctional epidermolysis bullosa, wound closure was actually more common in people treated with placebo compared to people treated with the therapy. However, the total number of people in this subgroup was small, and the trial wasn't designed to detect differences between these subgroups. So it's really unclear based on this data if people with junctional epidermolysis bullosa will have benefit with this therapy. In the Burimagene Japervovec study, there was unclear risk of selection bias, and wound duration was not reported. And then the Prademagene zamikeracel study had risk for performance and detection bias related to the open label design, particularly for subjective outcomes like pain improvement. And again, this study was the smallest study and enrolled only 11 patients. So there's a lot that we don't know about these therapies and where we just don't have data. There isn't any controlled data on long-term efficacy and safety of these drugs. There are some open label extension studies, but those have a lot of the typical limitations of long-term extension studies with high risk of attrition and lack of comparison groups. We don't have any data on other outcomes, including quality of life, prevention of infection, or prevention of skin cancer. We don't have any comparative data on the efficacy and safety of these drugs, so we don't know which one might work better or work better for different subgroups of patients. And these drugs have not yet been studied in combination. Similarly, we don't have data on retreatment of prademagene zamakeracel. In this clinical study, patients received the single dose and then were followed for long-term efficacy. So our recommendations currently are to implement prior authorization criteria for all 3 of these drugs, and to evaluate costs in executive session. Since we put forward our final draft documents, we have received a supplemental rebate agreement for prademagene zamakeracel, and if we wanted to entertain that supplemental rebate, we would have to make some changes to our PA criteria. I'll walk through what some of those changes might be, and then we can talk about the details of the supplemental rebate offer in executive session. So this is the PA criteria as proposed. The table 1 of the criteria outlines basically recommended dosing and indications based on the FDA label, as well as the genetic mutation that we would expect to be documented for diagnosis of the condition. And changes that we would need to make in order to accept the supplemental rebate offer for the prademagene zamakeracel are outlined in red here. So changing the maximum dose from 12 sheets per lifetime to just 12 sheets per dose, and then repeat dosing would be evaluated with the same criteria as the initial approval. So questions 1 and 2 in our initial approval criteria basically ask what's the diagnosis and then direct people to renewal criteria if applicable. Question 3 asks if it's an FDA approved indication. Question 4 asks for documentation of genetic testing to support that diagnosis. Question 5 asks about whether the prescribing provider has experience with epidermolysis bullosa management. Question 6 asks specifically about birch-triterpenes in people with junctional epidermolysis bullosa. This is an FDA indication for this drug, but people in the study actually did better on placebo compared to treatment for this population. So these requests would be referred to the medical director to assess appropriateness of therapy, document clinical severity, and the goals of therapy for that population. So undergoing kind of that secondary medical director review before an approval is made. And then in question 7, ask for documentation of the fact that the patient has current open and chronic wounds, including baseline wound size and estimated wound duration. So trying to get an baseline assessment so that we can assess benefit if renewal comes around. And then question 8 and 9 are the ones we'd need to change for prademagene zamikeracel if we wanted to entertain that supplemental rebate offer. So appreciate the committee's opinion on whether these changes are clinically appropriate. Initially, I had a question in here about denying concurrent use of more than one of these medications at a time because we don't have any evidence or any data to show if they're effective. They just haven't been studied in combination. That is a criteria that we'd have to change in order to take the supplemental rebate offer for the prademagene zamikeracel. And so instead, my recommendation is to put in a question for asking if the request is for retreatment of a wound or location that has been previously treated with prademagene zamikeracel. If not, then to approve the quantities up to the FDA-approved recommended quantity. And then on renewal, we're basically asking if the patient has had benefit from therapy based on decreased wound size, wound closure, or wound healing. So I'd entertain questions from the committee if they have questions or discussion or comments.
Sarah, I think that makes sense. The numbering is off on that one, but that's, I'm sure you guys will have figured it. So it should
Yes.
go to, yeah.
Right here.
Yeah. But no, I think that makes sense. And that will allow us, this language would allow us to take the supplementary rebate.
That's my understanding, yes.
Questions for Sarah? Oh, go ahead, Pat.
It's specifically no concurrent use permits the supplemental rebate.
That is my understanding.
Interesting.
Yeah, the way it's worded, that was our interpretation. It's no, like previous or current therapy. So it seemed like, it's to make sure there's nothing blocking the therapy from being approved. But if you read it and interpret it, this is the solution that was discussed and Sarah came up with that we think comports with the requirements of the supplemental rebate offer.
Yeah. And it really is an area where we don't have evidence. I mean, these treatments might work in conjunction, and they might not. We just don't know.
And we do have representatives that wish to provide public comment on 2 of the agents today. I don't know if they'll be able to answer that question, but when there are no more questions from the committee, we can entertain the public comment as well. Other questions?
Yeah, and this could maybe wait until after the public comment because maybe they'll address it. But is there like a real like case reports or anything where more than one agent is being used at a time? So like, is this something that we're even going to see?
That's the $3.2 million question.
Okay. All right. So maybe let's wait. Let's do public comment and maybe they'll answer that.
Other questions? I just got a chat that the first person wishing to provide public comment can answer this and address this. We have Leland Turner from Chisai Rare Diseases, manufacturer of Filsavez, which is the Birch terpenes. Are you able to unmute your line?
Yes, can you all hear me?
We can hear you loud and clear. And so, yeah, I'm going to put up my timer here. But with that, the floor is yours.
Okay, I guess I would just want to quickly, address, I don't want to speak for the other therapies on the line, but I do think it's important to remember for these patients, they're going to have anywhere between 10 to 60 or 70% of their body surface area covered in wounds, right? And so if you do use one of the gene therapies, they often have restrictions on the amount of area that you can apply that to the patient's body surface area. And that's not going to cover the entire, area of wound that they have. And so I think concurrent use, while it hasn't been officially studied, is something that you could really see in these patients, given the level of wounding that they have. We don't have any data currently. However, I can say, that is something that our company is looking into and that we are kind of actively pursuing in case reports. With that said, I'll dive into my public comment here about The Filsafez, burst triterpenes 10%, is a topical gel indicated for the treatment of wounds associated with both dystrophic and junctional EB in adults and pediatric patients ages of 6 months and older. This is a landmark pivotal study designed to assess the efficacy and safety in the EASE trial. We had the largest ever randomized placebo-controlled phase 3 study in EB patients spanning 28 countries, enrolling 223 patients across 59 total trial sites. And just a quick note, like there's only 35,000 people with any type of EB in the United States. And between Deb and Jeb, that's only 30%, that 35,000. So to get 223 patients is a pretty monumental achievement. Our enrollment consisted of patients, as I mentioned, with junctional or dystrophic. They were then stratified according to EB subtype, the size of the target wound, and age of the wound. 70% of our 223 patients were children with a median age of 12 years old. During the double-blind phase of EASE, subjects received a topical treatment of Filsafez or a control gel, not necessarily a placebo gel, but a control, as it was included sunflower oil and beeswax, which is known to have anti-inflammatory properties. That was applied to the wound every 1 to 4 days for a total of 90 days. I believe in the comment earlier, it was mentioned that our study was 45, but we did do the double blind for 90 days. The primary endpoint was complete first closure at 45 days. And our people who received the active ingredient had a closure rate of 41.3% of target wounds, paired with 1.9% on the control gel. Now, this endpoint positively contributes to the improvement in the quality of life for these patients and their caregivers. At the 90-day point of the double-blind study, all patients had the option to enter a 24-month open label phase using the active ingredient of Filsafez. At the end of that 24-month open label phase, the most frequently reported adverse events were wound complications, pyrexia, wound infection, pruritus, and anemia. These are all in line with the disease state, and it's nothing you wouldn't expect from the typical kind of EB. It's the EB disease, and I'll end it there since I'm at 5 seconds. Happy to take any questions if you'd like.
If you have a little bit more you wish to share, you used it to answer the questions at the start of the. So should have had you start with your presentation, then answer the question. But
that's my fault. That's really about it. The one thing, the most common cause of mortality in EB patients are going to be infection and squamous cell carcinoma. So in squamous cell carcinoma with patients who used Filsafez, there were 4 subjects who did develop a squamous cell. However, of those 4, only 2 of the squamous cells appeared in areas that had Filsafez applied to it. And we are engaged in a 5-year ongoing study monitoring the likelihood of squamous cells in patients who are on Filsafez at all. That's really all I had. And if you want to touch base outside of this, happy to do that.
Yeah, and appreciate your testimony. Any questions from the committee?
I guess the one last thing I would say in regard to junk patients is important that the only thing that is moved by the FDA for them. Nothing else is available for junction.
All right. Thank you, Leland.
Thank you.
Next, we have, you bet, Keith Dilley from Abeona Therapeutics, manufacturer of Zeviskin. Keith, are you able to unmute your line?
Hello, yes. Can everybody hear me?
I hear you loud and clear.
Super.
And the floor is yours.
Okay, thank you. Thank you for the opportunity to speak with you today. Let's begin with the unmet need in recessive dystrophic epidermolysis bullosa, or RDEB. This is a severe, ultra-rare genetic disorder caused by mutation of COL7A1 gene, resulting in the deficiency or absence of type 7 collagen. This leads to a lack of the anchoring fibrils that normally connect the epidermis to the dermis, causing extreme skin fragility and blistering. Clinically, patients present with chronic, painful wounds that are slow to heal, highly susceptible to infection, and associated with squamous cell carcinoma and significant morbidity. Current management is primarily supportive, relying on time-consuming and costly bandaging routines, along with symptomatic relief for pain and itch. While a topical non-cell-based gene therapy is available, it requires ongoing reapplication, and an unmet need remains for many patients, particularly those with excessive or chronic wounds, to achieve durable wound closure and sustained healing. Zeviskin is an autologous gene-modified cellular sheet indicated for the treatment of wounds in adults and pediatric patients with recessive dystrophic epidermolysis bullosa, RDEB. These sheets are engineered to express type 7 collagen at the dermal epidermal junction and are designed for a one-time surgical application where applied. The COL7A1 transgene integrates into the host genome at the site of application and is maintained through cell division, supporting sustained expression of type 7 collagen. In the pivotal VITAL study, patients treated with ZevaSkin demonstrated clinically meaningful wound healing, with 81% of wounds achieving greater than 50% of healing at 6 months, compared to 16% of control wounds, which underwent the standard of care of bandaging. Among those, 65% achieved greater than 75% healing, compared to 7% of control, and 16% of wounds reached complete heat closure, compared to 0% of control. In addition to wound healing, patients reported significant reduction in pain, benefits that are unique to ZevaSkin. ZevaSkin has an established safety profile in clinical trials. The most common side effects were pruritus and procedural pain. Serious allergic reactions, including anaphylaxis, may occur with ZevaSkin, and lifelong monitoring for the development of cancer is advised. No cases of squamous cell carcinoma have been reported in ZevaSkin-treated wounds, but SCC was observed in non-ZevaSkin-treated sites in 4 patients. ZevaSkin is designed to promote durable wound healing and reduce pain with a single surgical application where it's applied. As an autologous therapy, its gene-modified cellular sheets provide a personalized approach to managing wounds associated with RDEB, including large or chronic areas. And I'll yield the rest of my time and take questions. Thank you.
Thank you, Keith. Questions from the committee? All right, thank you for your testimony.
Thank
Again,
you.
we'll get the PA criteria up in front of you and the recommendations again. Implement the proposed PA criteria for these high-cost treatments for epidermolysis. I can't even say it, Sarah. So, epidermolysis bullosa, and we are going to evaluate the cost. So, do we have a discussion or motion to approve the PA criteria?
I guess maybe I'm overthinking this, but may like the supplemental rebate in some way inform the appeal of having like the no concurrent use line?
You bet. So what I'm hearing you say is let's defer the recommendation on the PA criteria yet. Let's look at what that offer is in exec session. We won't be discussing really the clinical merits of that, but what it looks like, and then we'll bring it back out to open session to discuss the PA and discuss the recommendations on the PDL.
I think so. Yeah, you said that perfectly.
Yeah,
And
I like it, Pat.
I did
okay.
too.
All right. Anybody on the committee opposed to take that action? Super. I think that's wise. Hearing none, we'll move on. Draw your attention to page 93 in the packet. We have the carglumic acid new drug evaluation. And Deanna, we're going to turn it over to you.
Thanks, Roger. So this is another high-cost drug that we'll be looking at. If we could go to the next slide. So our 3 research questions were to look at the efficacy of carglumic acid in managing specific urea cycle disorders, including the N-acetylglutamate synthetase or NAGS deficiency, and then the 2 acidemias that it's also been approved for, the propionic acidemia and the methylmalonic acidemia. And then we also wanted to look at the harms of carglumic acid in managing these 3 disorders. And then are there any differences in subgroups? So if we could go to the next slide, please. Just a little background. Urea cycle disorders have an overall prevalence of about approximately 1 in 30,000 live births, and the primary physiologic consequence is high ammonia due to the inability to convert the ammonia to urea so it can be excreted. And then the organic acidemias are another rare class of inborn errors of metabolism that is characterized by accumulation of the organic acid metabolites. So just for context, in the past year, we had 11 patients that were enrolled in OHP CCOs and 2 patients in fee-for-service that had claims for the NAGS diagnosis. And then there was 2 patients in the CCO population that had the PA diagnosis, while 31 CCO patients had a diagnosis of the MMA. And in fee-for-service, there was no patients with the claims for PA, while there was 4 patients that had a claim for MMA. Next slide, please. So how carglumic acid works is it's a structural analog of N-acetyl-glutamate synthetase, or NAG, and the carglumic acid activates the phosphatase synthetase, which is needed to convert ammonia into urea so it can be excreted into the urine. There's 3 FDA-approved indications for carglumic acid in pediatrics and adults. So the first is for treating acute hyperammonemia due to NAGS deficiency. And then second is the maintenance therapy for treatment of high ammonia in patients with NAGS deficiency. And then thirdly, it's as an adjunctive therapy to the standard of care for treatment of acute hyperammonemia due to PA or MMA. If we could go to the next slide, please. So the efficacy of carglumic acid in NAGS deficiency was evaluated in an unpublished retrospective case series of 23 patients that had NAGS deficiency. The study is not published, and the study details were limited to the prescribing information issued by the manufacturer. In this retrospective case series, the patients were treated with carglumic acid over a median duration of 7.9 years with a range of 0.6 to 20.8 years. So the short-term efficacy was evaluated using mean and median changes in plasma ammonia levels from baseline to days 1 to 3. And then the persistence of the carglumic acid effect was evaluated looking at long-term changes in plasma ammonia levels. And so the results are in that final bullet there. By day 3 of treatment with carglumic acid, the mean plasma ammonia levels had normalized, and they remained within or near normal range during long-term treatment, which ranged from 7 to 249 months. And because it's an observational trial, the evidence is low quality. If we could go to the next slide, please. The clinical efficacy in PA and MMA deficiency is also an unpublished study that was limited to getting the details from the prescribing information issued by the manufacturer. In this randomized double-blind placebo-controlled multi-center trial, they looked at the efficacy of carglumic acid in treating high ammonia in patients with these 2 inborn errors of metabolism. So participants had to have a hyperammonia episode, and it was defined as an admission to the hospital with a plasma ammonia level that was 70 micromoles per liter or higher. And they were randomized 1-to-1 either to receive the carglumic acid or placebo for 7 days or until hospital discharge. And the primary endpoint was time from the first dose of drug to either the lowering the plasma ammonia level to less than 50 micromoles per liter or hospital discharge. So this was based on 90 episodes of high ammonia levels. 42 patients got the carglumic acid and 48 were treated with placebo in a total of 24 patients, and they were equally divided by gender. There was more patients that had the PA versus the MMA. So the median time to reach the primary endpoint was 1.5 days in the carglumic acid group compared to 2 days in the placebo group. And the difference was half a day. And that was not significant based on the confidence interval that was presented. We could go to the next slide, please. There's another prospective randomized open label study that was funded by the manufacturer that is available, and that compared the efficacy of adding carglumic acid at the usual dose of 50 milligrams per kilogram per day in divided doses twice daily to standard treatment in patients with PA and MA. And the standard treatment followed the most recent guidelines of using L-carnitine and metronidazole, as well as a protein-restricted diet. This study was conducted in 2 tertiary care centers in Saudi Arabia. And the study was open label as patients could present to the ER with an acute crisis, and the attending physician would need the details of their treatment regimen. Additionally, according to the emergency protocol for management of these acidemias, carglumic acid is considered a rescue medicine and should be used in all patients that have high ammonia levels, even for those in the standard treatment arm. So the primary outcome was long-term effectiveness over 2 years of carglumic acid in reducing the number of emergency department admissions due to having high ammonia in these patients that had these inborn errors of metabolism. So 38 patients were enrolled in this study, 21 were randomized to the carglumic acid plus standard therapy, and then 17 were just allocated to the standard therapy arm. The mean age of the participants was approximately 36 months in the standard treatment arm, and in the carglumic acid arm was 40 months. So the total number of ED admissions was 12.76 in the standard treatment group and 6.31 in the carglumic acid group over 24 months. So the regression analysis suggested that carglumic acid achieved a 51% significant reduction in the number of ED admissions compared to standard therapy. They did look at plasma ammonia levels from baseline and to the end of the study, and that did not show any significant difference between the arms. And they also looked at other biochemical markers, and there was no significant difference in the levels of other plasma amino acids. If we could go to the next slide, please. In terms of safety, in the retrospective case series of the 23 patients, 17 of the 23 had an adverse reaction. The tables in the packet on page 98 and 99 show the specific adverse reactions, but the most common adverse reactions were vomiting, abdominal pain, pyrexia, tonsillitis, anemia, diarrhea, infections, decreased hemoglobin, and headache. In the randomized double-blind placebo-controlled clinical trial, 24 patients, 15 with PA and 9 with MMA, had at least one adverse reaction during their, and about 42% of the hyperammonic and the high ammonia episodes. And the most common adverse reactions in this study were neutropenia, anemia, vomiting, electrolyte imbalances, decreased appetite, hypoglycemia, lethargy, encephalopathy, and pancreatitis or increased lipase. In the next slide, the manufacturer does recommend that the dose be modified if patients have moderate or severe renal impairment. So the guidance is listed there. That's not part of the PA criteria. The idea would be if someone's prescribing this, that they would be familiar with the dosing and would modify the dosing as needed. If we could go to the next slide. We'll talk about the PA criteria. So this just follows our standard PA process of looking at first, what's the diagnosis? Is it a request for continuation of therapy? If so, we'll go to the renewal criteria. Then our standard PA criteria asks, is it an FDA-approved indication? Question 4 goes on to say, is it one of the 3 FDA-approved indications? And then we want to make sure that it's been, the diagnosis has been confirmed by genetic testing, also to make sure the patient's on a protein-restricted diet and that baseline ammonia levels have been documented. And then also we want to make sure it's prescribed by someone that has expertise in managing urea cycle disorders or organic acidemias. And then finally, we would ask, is it the request for a preferred product? If we go to the next slide, this is just the renewal criteria, and we would ask, is it an FDA-approved diagnosis? And then does the prescribing provider attest that the patient has improved? And with that, I would open it up to the recommendations, which are to make one carglumic acid product preferred. There's a generic product on the market as well as a brand name product. And we'll talk about the costs in executive session. But at this point, I'd like to ask the committee if they have any questions about the prior authorization criteria. And if not, I think we have one person that would like to provide public comment.
That's correct. Good job, Deanna. Any questions for Deanna? All right, we do have representative from Recordati Rare Diseases, Andrea Hawkinson. Andrea, are you able to unmute your line?
Yes. Can you
Can
hear
hear you
me?
loud and clear. Yeah,
Okay.
and the floor
Okay.
is yours for up to 3 minutes.
Great, thank you. So good afternoon. I am a medical science liaison with Recordati Rare Diseases, and today Recordati Rare Diseases is making the request to the Oregon State P&T Committee in support of patients with rare urea cycle disorders. So the availability of ammonia-lowering medication is essential to these patients who suffer from UCDs and specific organic acidemias, as mentioned. Recordati Rare Diseases is requesting that Carbaglu carglumic acid tablets for oral suspension 200 milligrams be the preferred treatment over the generic carglumic acid for the three indications: adjunctive treatment of acute hyperammonemia due to propionic acidemia or methylmalonic acidemia, adjunctive treatment of acute hyperammonemia due to NAGS deficiency, and maintenance treatment of chronic hyperammonemia due to NAGS deficiency. So this request aligns with the current FDA approval for the different carglumic acid formulations currently available. Carbaglu is currently approved for use in these three indications, whereas generic carglumic acid is only approved for individuals with NAGS deficiency. Now, to put this into perspective, the incidence of NAGS deficiency is less than 1 in every 2 million. For PA, it is 1 in every 100,000, and MMA, 1 in every 50,000. And according to the Oregon State Newborn Screening, there is screening for PA and MMA, but not NAGS deficiency. Hyperammonemia is a medical emergency, and therapies need to be started as soon as possible to prevent decompensation and death. And individuals with NAGS deficiency, PA, and MMA do not break down nitrogen correctly, resulting in the toxic ammonia accumulation, and require different ammonia-lowering medications than the more common ones. Thus, Carbaglu is an essential treatment for these three rare conditions. NAGS deficiency is typically identified in decompensating neonates that require hospitalization and immediate implementation of a complex management strategy. The guidelines for diagnosis and management of UCDs by Haberle in 2012 are still in effect, stating Carbaglu is recommended as first line for the treatment of NAGS deficiency. Additionally, the FDA approved the use for acute hyperammonemia with PA and MMA in 2021. So these are fragile patients that risk serious and life-threatening conditions without daily management, including carglumic acid and other management strategies. So as the only carglumic acid approved for NAGS deficiency management and acute crisis stemming from hyperammonemia due to PA or MMA, we humbly request that the committee to consider Carbaglu tablets for oral suspension be the preferred treatment over generic carglumic acid and to not be considered interchangeable with generic carglumic acid. Thank you.
Thank you, Andrea. Any questions for Andrea? All right, again, thank you for your testimony. So the recommendations are on the screen for the committee. Make one of the carglumic acid products preferred on the PDL with the approval of the PA criteria as proposed to ensure it's being used in the appropriate populations, and we are intending to review an executive session. Any discussion or move to approve?
I'd like to move to approve.
Second.
Thank you, Samara.
Right, thank you. Do all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
All right. Next, we have our Niemann-Pick type C new drug evaluations. It starts on page 105 in your packet, and we'll turn it over to Sarah Fletcher.
Thanks, Roger. Yes, if you can go to the next slide, we're looking at a new drug evaluation for 2 new agents for Niemann-Pick disease type C. These are also both carve-out medications, as is miglustat, which I'll get to in a second. If you go to the next slide for background, Niemann-Pick disease is an autosomal recessive disease with 3 distinct pathologies for type A, B, and C, and type C is a neurologic disorder resulting from toxic cholesterol accumulation. It has 3 or 4 different phenotypic presentations, and generally the earlier the onset, the more aggressive the disease and the worse the prognosis. There's no cure, and fewer than 10 patients were identified in the Oregon Health Plan who have this disorder. If you go to the next slide for miglustat, that's a different agent that I just wanted to touch on briefly. It's approved for the neurologic manifestations of Niemann-Pick type C in other countries. It was reviewed by the FDA in 2010 and got a complete response letter, and they asked for additional data. Since then, miglustat has been approved for Gaucher and Pompe disease, so it is on the market and available off-label for Niemann-Pick type C. The dosing that's often used for Niemann-Pick is 100 milligrams daily to 200 3 times a day, depending on the age and body surface area. And currently, with some 2018 guidelines based off experts in North America and Europe and Australia, most patients should be considered miglustat therapy. That was a weak recommendation, and it was based off low-quality evidence, and there was some disagreement with that particular amongst the experts. But there was a lot of agreement that pre-symptomatic patients who only have liver and spleen involvement should not be offered miglustat, and those who have advanced neurologic disease or other life-threatening illnesses should probably not begin on miglustat. Those were all weak recommendations based off low-quality evidence. Miglustat's data, there are multi-year longitudinal cohorts and other trials, and it seems the efficacy is probably better with those who have a later onset of the condition. If you go to the next slide, one of the 2 agents that we're going to review is arimoclomol. Now, its mechanism of action, just like the next one, is unknown, but it's a small molecule that crosses the blood-brain barrier and is thought to affect the heat shock response and prevent misfolding of proteins that can preserve cellular function. It's FDA approved in combination with miglustat for the treatment of the neurologic manifestations of NPC in patients 2 and older. So it's approved in combination with an off-label medication, which is required. They have to go together. Let me go to the next slide. The approval was based off of a single study. It was a randomized, double-blind, placebo-controlled phase 2/3 trial. It was randomized 2 to 1 with 34 patients in the arimoclomol group and 16 placebo. And then there were subgroup analyses for those who were taking miglustat at baseline, which was about 78% of the population. Inclusion, it was only those 2 to 19 years old, which is important compared to the next drug that we'll look at. They did have an NPC diagnosis and at least 1 neurologic sign of the condition and were able to walk independently or with assistance. The duration was 12 months, and the tool that was used for the assessment was the Niemann-Pick type C clinical severity scale. I talk about it a lot in the review, but the FDA for all of these outcome measures had quite a few comments and they did modifications. And so this 4-domain scale used ambulation, speech, swallow, and fine motor skills. And it's a 0 to 20 point scale where higher scores indicate more severe disease. And so you can see that arimoclomol had lower scores for that compared to placebo after a year in the miglustat subgroup. The FDA said that the group without miglustat had insufficient evidence of benefit. Also, I included one of the secondary outcomes, the clinical global impression improvement responder rating, and there was no difference between the 2 outcomes for that one. And I did want to point out, because of the age of inclusion, there were no patients who had the adolescent or adult onset of this condition in this particular trial. If you go to the next slide, some of the limitations. I've touched a little bit. The FDA has some concern with the particular assessment tool as well as the procedures. The assessors were given training, but the caregivers often had to give histories to be able to do scoring of the tool, and they were not given training or daily diaries to record information. The order of assessments was not standardized, and in some sites where other assessments were given first, certain domains typically scored higher, enough that it was statistically noticeable by the FDA. And then there was retroactive baseline scoring for some assessments, such as the CGI had 84% were entered retroactively. There was also uneven attrition and an early escape clause where a couple patients were unblinded because of rapid progression who were in the drug treatment group. There was no missing data imputation with the primary analysis. And there were some baseline differences as well. And as I mentioned, there were no adult or adolescent onset patients in this study. And the sample size was based off of duration and feasibility instead of a sample size calculation. If you go to the next slide. As far as clinical safety, it's a pretty small trial. 3 patients withdrew due to adverse events, urticaria, angioedema, and an increased serum creatinine. This medication is known to cause a reversible increase in the serum creatinine that does not indicate kidney failure. It just reduces the transport of creatinine into the renal tubules for excretion. There was 1 death. It was unlikely to be related to the medication. There are a few warnings and precautions that I have listed, and then the most common adverse events were upper respiratory tract infection, diarrhea, and decreased weight. Now, if you go to the next slide, you shift gears to the other medication that has this indication for Niemann-Pick type C disease. This is levocetyleucine, and it's the L and enantiomer of the acetylated amino acid and prodrug for leucine, which is an amino acid. The mechanism of it is also unknown, but it does cross the blood-brain barrier and is thought to correct metabolic dysfunction and improve some energy production with adenosine triphosphate. It has the approval for treatment of neurologic manifestations with Niemann-Pick type C in adults and peds weighing at least 15 kilograms. If you go to the next slide, this one was also approved based off a single study. This one was a crossover study that was placebo-controlled. It had 60 patients total. The age range for this one was 5 to 67, and about 18% of patients were under 38, and about 85% of patients were taking concomitant miglustat. It had a similar NPC diagnosis requirement, and then patients needed a baseline SARA score of 7 to 34. Now, the SARA is a 0 to 40 point scale where, again, higher scores indicate worse status. And the major exclusion criteria were things like other trial participation. And this trial was much shorter. It was only 12 weeks long. And then you had a crossover with no washout and then another 12 weeks. And you can see the primary outcome for the SARA score, which is the scale for assessment of rating of ataxia. You can see the difference of levocetyleucine was negative 1.97 versus negative 0.6 for placebo, which was statistically significant. Now, the FDA did not use the SARA in their approval process. They used what they called the functional SARA, which took out 8 domains, and it took out 4 of them and only included gait, stance, sitting, and speech. And then it rescored the scale so that all of them had equal weight, which in this normal SARA scale, some of them have higher weight than others. And so it's a 0 to 16 point scale for the FSARA. And you can see that there is a negative 0.45% or difference between the 2 medications. And that was also statistically significant. The baseline SARAs, I could have included in the demographics, was about 15.8 or 15.7 for these groups. And so it was about middle of the range between the 0 to 40 point scale for their baseline. If you go to the next slide, the trial limitations, the FDA also had concern with the SARA tool. And as you can see, they modified it as well in their assessments. The crossover design without washouts limits the safety data. It also limits some of the efficacy data because you don't have a washout to see what the effects could be when you switch from one drug to another. And it was a short duration for such a long-term progressive condition. I did find information that about a 1 point change on the SARA may be clinically significant, but it's unclear for the functional SARA, which is 0 to 16 scale, if that would be a clinically significant difference. Now, for clinical safety, there was 1 withdrawal with subsequent death that was unrelated to treatment. It had to do with complications from a G2 placement. For warnings, precautions, there's embryo-fetal toxicity, which was also present in the other medication. And then the most common adverse events were, again, upper respiratory tract infection, abdominal pain, dysphagia, and vomiting. And so if we can go to the PA criteria, I have 2 new PAs and then some modifications to 2 others. We're going to switch to the packet now. Okay, so this is the first new PA, and it's for the 2 new medications that do have indications for Niemann-Pick disease. And as I mentioned, they are also both part of the carve-out. And so questions 1, 2, and 3, what's the diagnosis? These are pretty standard. Is it continuation? And in number 3, I do exclude the ability to use combination therapy. I couldn't find it. They're both just now on the market. There's 1 trial supporting the efficacy of each. There's no information on safety or efficacy of the combination. If the committee has concerns about that, we can talk about that. You can scroll down. We have diagnosis and then expert for 4 and 5, and then having at least 1 neurologic manifestation of the disease, which is part of the approval for both of them. And then in 7, we asked for baseline assessment of their current status. 8, 9, and 10 are all related to the embryo-fetal toxicity, and those are pretty standard questions. And then for number 11, and if you scroll just a little bit for 12, these are some wording we're going to try to add to some of these longer term carve-out medications because of the rarity, the paucity of data, the expense. We really want some goals on when it's appropriate to continue the therapy and when it's not appropriate to continue the therapy. And because they're all such unique cases and unique patient-provider relationships where they can make that best, we tried to put in some language for how to address that so that we are looking at the medications for long-term use, but also really seeing if there's actually any kind of benefit that's being given from them. If you go to number 13, I ask, is the request for a patient who's at least 2 years old, which is part of the labeling, and ambulatory, which was part of the patient population studied as far as severity of disease. And then for 14, there is the requirement that miglustat is used concomitantly, and that there is also a request for miglustat that will be approved. 15 is for the request for levocetirizine weighing at least 15 kilograms, which is also part of the labeling. Now, if you scroll a little bit further, we've got renewal criteria. Number 1 is adherence. Number 2 and 3 are related to those documentation of goals of therapy and pre-established criteria for unsuccessful treatment and lack of response, and then risk versus benefit for ongoing therapy. So are there any questions about this one before I move to the next one? I know it's a whole new PA. Okay. Let's move on to the next one, which is miglustat. I've pulled miglustat, the 100 milligram capsule, which has 2 brand names and a generic product, out of the Pompe and or out of the Gaucher and Pompe disease, or edited the Pompe and Gaucher disease PAs to make a new one here. Miglustat is also in the carve-out for both dosage strengths. And so we've added it here for Niemann-Pick, and then I've pulled in the information from the Gaucher disease PA to include it here as well. So for number 1, it's the diagnosis again and fee-for-service treatment. Scroll down a little bit. Number 3 is expert. Number 4 is it for Niemann-Pick type C, and are they at least 2 years old, which is the lower end of the arimoclomol approval range. And then I would like to make an amendment for number 5. Yes should go to what is currently number 11, and we're going to delete number 6. We have a duplicate there. But if it's not for Niemann-Pick, we'll get to number 7. And for 7, 8, if you keep scrolling, these were directly out of the existing Gaucher disease approval. I didn't add anything. I didn't change anything. It looked like the approval for how you would have gotten miglustat through that pre-existing PA. And then number 11 is the request for a non-preferred product, and will the prescriber change to a preferred product? As I mentioned, there's 2 brand names and a generic, and they're all interchangeable. And so for this one, we're going to try to do a hard stop for if we do choose to make a preferred product an executive session. If we leave them all as non-preferred, we'll take these questions out. But if the provider does not want to change, then we would like a documented failure or the inability to access, because they're bioidentical drugs. We're not asking for a change between similar drugs. It's the same thing. Then if you go to the renewal criteria, these are also basically based out of what was in Gaucher disease. Do we have any adverse reactions? Are they being reported? Is there adherence? And then is there an objective documentation of the benefits of the continuation of treatment? Any questions on this one? Okay. And then I just have clerical changes. We can go through Gaucher really quickly. I took miglustat out, and I took it out of a couple, some clerical changes just a little below. Everything else should flow the same. And then for Pompe, all I did was clarify that miglustat is in the carve-out, whereas the other medications for Pompe are not in the carve-out. But it didn't make any additional changes to the flow of the approval. Miglustat for Pompe is used as a pharmacokinetic booster, basically, for one of the other medications. And so if you get approved for the 3rd drug that starts with a C, then you should get approved for miglustat. Okay, can we switch back to the slide deck then? The recommendations are to make arimoclomol and levocetirizine non-preferred, and to implement the prior authorization for the high-cost treatments of Niemann-Pick disease and to implement a separate miglustat PA for the 100 milligram formulation with that modification that I mentioned a few minutes ago about taking out question 6, and corresponding updates to the Pompe and Gaucher disease PAs, and then to evaluate costs in executive session. And I think we
a lot
have
of information. Good job, Sarah. Yeah, we do have one person that wants to provide public comment, but any questions from the committee for Sarah first? All right, hearing none. We have Janelle Raymond from Intrabio, manufacturer of Acnursa. Are you able to unmute your line?
Yes, can you hear me?
I can hear you loud and clear.
Wonderful.
And so the floor is yours.
All right, thank you. So thank you for this opportunity to provide comment. I'm one of the medical directors here at Intrabio, and I want to address the committee regarding levocetoleucine and provide some updates that's outside of the label that we have since published. So as mentioned, levocetoleucine or Acnursa is approved for the treatment of neurological manifestations in NPC in both adults and pediatric patients weighing 15 kilograms or more, and it can be used with or without miglustat. Acnursa was evaluated in the global phase 3 study that was just gone through, and that's what's in the product labeling. And following this initial phase, participants could continue into an open label extension. This open label extension is still ongoing at our European trial sites, and we also enrolled an additional cohort allowing participants to join at birth. The extension phase has had data readouts at 12 and 18 months, and these data have been published. I did provide a manuscript for the review for the committee, but I believe it was past the deadline. So I'll give a brief overview of those extension phase results now. The primary endpoint of the extension phase was the modified 5-domain Niemann-Pick disease type C clinical severity scale. So that looked at all the ones that were just mentioned in addition to cognition, and a higher score on this scale indicates worse neurological status. So after 12 months of treatment with levocetoleucine, the mean change from baseline was negative 0.32 points. After 18 months, the mean change for baseline was negative 0.067 points. And both of these are reflective of an improvement in neurological status that's sustained over 12 and 18 months. And when you compare that to natural history data, 12 months of treatment with levocetoleucine is associated with a 120% reduction in annual disease progression. We more recently presented 24-month data, and they're consistent with the 12 and 18-month data readouts, showing a halt in disease progression on both the SARA scale and the NPC CSS. So this demonstrates a sustained and clinically meaningful improvement with continued treatment. Out to 24 months, there were no new safety signals. There were no serious drug-related adverse events. So this reinforces the safety profile in the parent study. Just for your awareness, there have been multiple states that have already updated their criteria following the release of our long-term extension, and they're in favor of Acnursa. And we do have exclusivity with the DoD and TRICARE. And I'm happy to answer any questions that you may have related to this new information.
Appreciate your testimony, Janelle. Any questions from the committee?
I have a quick question. Has the historical cohort data been published? I was unable to find it, but if you have it, I would love if you could send it to us after the meeting.
Yes, it has been published, and I am more than happy to send that. Who would be the best person to forward that to? Just the main point of contact?
Yes.
Okay.
Any other questions? All right, thank you. All right, to the committee, the recommendations are up on the screen. So propose to make the 2 agents non-preferred on the PDL, implement the proposed PA criteria for the Niemann-Pick, and implement the separate PA for miglustat 100 and the corresponding changes to the PA criteria for Pompe and Gaucher. We are going to look at these in executive session. Any discussion? All right, any motion to approve? Did I speak over somebody for a motion?
Yeah, it was just Pat. All motion.
It's not just Pat. Thank you for the motion, Pat.
Second.
Great, thanks, Nora.
All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thank you.
All right, we're just about on schedule, so we're planning to have a 15-minute break. I am going to put the timer up on the screen. And with that, we'll see you back here in 15 minutes. Thanks, everybody. All right, we're getting back from our break. I'm going to stop the timer. Take a look quickly at the committee. Looks like we absolutely still have our quorum, and we still have a bit of the agenda to get through. So if you're following along in the packet of materials posted to our website, draw your attention to page 136. We have the PAPZIMEOS new drug evaluation. We'll turn it over to Kathy Centena.
Great, thanks, Roger. So yeah, today we're going to be talking about PAPZIMEOS or zopapogene, which is an orphan drug approved for the treatment of recurrent respiratory papillomatosis or RRP. As already was discussed, it's part of that high-cost drug carve-out. So that's why I'm going to be looking at it today. Just a little bit of background. RRP is a rare chronic variable disease with an incidence of 4.3 per 100,000 children and 1.8 per 100,000 adults in the United States. RRP is caused by the HPV type 6 or 11 virus, which results in recurrent growth of papillomas in the upper and lower respiratory tracts. The disease patterns are variable from spontaneous remission to aggressive persistent disease. It's a very heterogeneous disease with no predictive measures to determine the likelihood of papilloma reoccurrence. Adult onset usually occurs between 20 and 40 years and is typically transmitted through sexual contact, where in children, RRP is usually acquired via transmission from mother to child during birth. The clinical symptoms of RRP are dysphonia, stridor, dyspnea, chronic cough, and airway occlusion. And then it can also cause other more serious side effects or more serious issues such as recurrent airway lesions, which lead to a loss of lung volume, post-obstructive pneumonia or respiratory failure, and occasionally it can cause malignant disease. So the treatments for this are few. Zopapogene is one of the only FDA-approved drug therapies for RRP. HPV vaccination is effective at preventing disease, and vaccination may decrease the number of surgeries required in patients that already have RRP, but that evidence is limited. So right now, the standard of care is repeated endoscopic debulking of lesions by ablation or surgical excision, with additional adjuvant off-label targets that include immunomodulators, disruption of HPV replication, inflammation control, and prevention of angiogenesis. Unfortunately, adverse reactions associated with these agents, as well as variable effectiveness, prevent their routine use as adjuvant therapies. So when we're looking at RRP, there's several things that we use to monitor efficacy as well as effectiveness of treatments. The first being the number of interventions, if they help decrease the need for surgeries, laser ablations, and things like that to remove the papillomas. The Derkay score is often used as well. It's a staging system that measures the number of papillomas and the bulkiness, as well as assessing the clinical symptoms such as voice quality and stridor. Each question has a score that ranges from 0 to 3 with a maximum score of 75. Of course, the higher scores indicate more severe disease. The Voice Handicap Index is also used, and it measures the extent of voice disorder that interferes with the patient's quality of life. So those scores range from 0 to 40, with anything above 11 considered abnormal, with an MCID of 6 points or more. Or sorry, a 6-point or more decrease. So when we look at zopapogene, the mechanism of action is that it's a non-replicating adenoviral vector-based immunotherapy that enhances T-cell responses to detect and then reduce cells infected with HPV. The approved indication is immunotherapy indicated for the treatment of adults with RRP. So again, at this time, it's only approved for adult use. It's given as a 5 × 10 to the 11th particle unit per injection, and that's administered sub-Q 4 times over a 12-week interval. So when we look at the specific study used for that was used as evidence for approval, this was an open label phase 1/2 single center, single arm study. And it looked at zopapagine, again, given subcutaneously, and that the doses were given on day 1, 15, 43, and 85. These patients were a median age of 49 years. Most of them had been diagnosed around the age of 35. They'd had a number of lifetime interventions for RRP of 40 with a median Derkay score of 8. This is a moderate level of severity, so the average kind of ranges from 8 to 17, where scores above 20 indicate higher severity of disease. The median VH1-10 score was 24, which means that indicates a moderate to severe handicap. So for inclusion criteria, the study enrolled adults who had histological and clinically diagnosed RRP and had 3 or more debulking procedures to remove laryngotracheal papillomas in the 12 months prior to treatment. So in this study, what they looked at for the primary endpoint was the complete response rate. So that was defined as the percentage of patients who did not require an intervention to control RRP in the 12 months after the treatment ended. And you can see here that 51% of patients met that outcome. For a secondary outcome, they looked at the number that if fewer number of interventions 12 months after treatment were required compared to the 12 months before treatment, and 86% of patients met that outcome. If we look at the clinical safety, they're listed here in the table. You can see that most of these adverse reactions are due to activation of the immune system. One of them that I want to point out specifically is that there's a very high percentage of injection site reactions, and they do recommend that you monitor for local injection site reactions for up to 30 minutes after the initial treatment. One severe adverse event that's associated with viral vector-based therapies is thrombosis. So this should also be monitored for. This is caused by cytokine-mediated coagulation, as well as endothelial activation and platelet activation that can occur with these viral vector therapies. Now, looking at the evidence limitations, there were quite a few. There was a high risk of selection and performance bias based on the study design because it wasn't randomized, it was single arm and it was open label. The assessment of the RRP was done by the patient's home care team, which could introduce significant variability in outcome evaluation and increase the risk of detection bias. Again, since RRP is a heterogeneous disease and fluctuations in disease severity over time are unknown, again, about reoccurrence, having the primary outcome evaluated at 12 months may not necessarily predict long-term durability or additional needs for surgery. Again, there's no long-term studies or studies on chronic use, and evidence of efficacy with repeated doses has not been studied. Zopapagine has also not been studied in pregnant women. And again, there's unknown safety effects when more patients with more severe RRP are studied and when the drug is given to a wider population. So we're proposing a PA criteria here to allow for the use of Papzimeos for RRP in patients who have had persistent disease despite surgical interventions. And as I mentioned, there aren't alternative treatment options for this other than surgery. So for the criteria, we ask what diagnosis is being treated. We ask if this is an FDA-approved age. As I mentioned, Papzimeos is only approved in adults. If yes, then go to 3. And we ask if the request is for a patient with recurrent respiratory papillomatosis, the RRP. And we're defining the recurrent as a need for 3 or more debulking procedures for papillomas related to RRP in the previous 12 months. And this is the same as the inclusion criteria in the study. And if yes, just asking if the patient has been previously treated. And if yes, deny, because we don't have evidence beyond just one treatment. But if no, then approve the one treatment course, which is the 4 doses over 12 weeks. So the recommendation is to make zopapagine non-preferred on the PDL and to implement PA criteria to allow for coverage for adult patients when other RRP treatments have failed. And I know we have public comment on this as well.
We do. So great job, Kathy. Any questions for Kathy? All right, we have Amber Svardo, representative from Precigen, the manufacturer of Papzimeos. Are you able to unmute your line?
I am, but we also have Andrew from OHSU. So if we're just limited to the 3 minutes, if he could go first and then I'll follow up.
You can each have 3 minutes, so the floor is
Okay.
yours.
Well, even better. So really quickly, I just want to say thank you for having me today. A little bit more about our study design. This study was designed in conjunction with the NIH and FDA to be statistically powered to determine treatment effects that are needed to look at these more severe patients to show that this drug has a clinical impact. The patient served as their own control, which is common in these rare diseases when it's difficult to do a randomized control trial. Based on this data, the FDA did not require in our label a certain number of surgeries for these patients. I also want to note that the 3 surgeries could include the first surgery prior to day 1 dosing of the product. So really it was 2 surgeries, and then that third one was in conjunction with the first dose. We do have longer term durability data as well for those 18 patients who had the complete response at 12 months. We now have a median of 3 years of data, which shows that 15 of those 18 patients still maintain a complete response, meaning they have not required any additional surgeries or any other adjuvant therapies to control their disease. The patients were treated at the NIH for the 12 weeks of therapy, but as you mentioned, they were monitored after by their home otolaryngologist, as well as before those previous 12 months by their otolaryngologist. We also did get full approval, so no phase 3 is required for this study from the FDA because of the statistical significance we showed with that complete response rate. I also want to point out that patients, with each surgery, there's a 32% increased risk chance of damage to their larynx or their vocal cords, which can be very debilitating for these patients. Damage to these vocal cords can affect their careers and their home life as well. No matter how good the surgeon is, there's always that risk of damage to the vocal cords. Patients have a 32 times more likely chance of developing cancer if they do have pulmonary spread, and these RRP patients do have a risk of up to 9% at least of pulmonary spread. So just wanted to point that out as well. I think that's all I have to say.
All right. Appreciate it, Amber. Any questions from the committee for Amber? Okay. We also have Andrew Albanese. So Andrew, you work up at OHSU.
Yes.
A representative, or you're not employed by the pharmaceutical manufacturer. So give a little
Not at
background
all.
for the committee so they understand your conflict. You've been asked to testify today, so I'll let you give that background.
Oh, absolutely. Thank you all for your time. My name is Andrew Albanese. I am the ambulatory director of pharmacy at Oregon Health and Science University, but I am also part of the Gene Therapy Oversight Committee here at OHSU, and I personally oversee the implementation of gene therapies at OHSU. And I've been doing this for quite a while, for about 8 years.
All right. Well, that proceed with your testimony. Interesting.
Yes.
We don't usually have representatives or hospitals and our surrounding people coming to testify on behalf of a particular manufacturer. So interested to hear what you're having to say.
Yeah. So absolutely. I get the honor to collaborate with our providers here at OHSU to treat patients that receive gene therapies and rare disease drugs. And this one is of a particular interest because we do have a large number of patients that we would obviously love to treat. So I'm here to give testimony with the hopes that PAPZIMEOS could be covered and be more available to our patients here in Oregon. So again, PAPZIMEOS, as labeled, is indicated for the treatment of all adults with recurrent respiratory papillomatosis. It was studied in a more aggressive form of recurrent respiratory papillomatosis. However, as Amber mentioned below, a lot of the reasoning was to ensure that the outcomes were powered and it would be statistically significant. With these surgeries, I have learned with working with our providers and clinics that it does have a pretty significant risk every time a patient does receive an ablation or any type of debulking procedure. And so, the ultimate, the benefit of this drug is not only the cure rate, but also of just preventing these surgeries, these debulking procedures, because of the really negative impact on our patients, our RRP patients here in Oregon. And so after the risk gets really bad after 10 lifetime surgeries, and those surgeries could occur once a year, once every few years for these patients. Again, if it's a 40-year-old patient, they could have just been having one surgery a year for the last 20 years, but still losing really the ability to speak and other, again, effects that Amber mentioned. So every surgery comes with a risk, and over time, especially in our older patients, even if just having one or two surgeries a year, they still have the disease and are experiencing the negative effects, and every surgery just comes with a huge risk to the patient's ability to speak. So I personally, I thought this was important, and am passionate about our patients in Oregon and in gene therapy. And so I'd like to advocate again for the coverage for the medication as labeled, or at least kind of what Amber was describing of maybe 2 surgeries, and we have to do a surgery before we could use the drug. I just think that this could have a massive, profound impact on patients for even that haven't have a more serious form of the disease, but just even if they've had one debulking procedure in the past year. So I think PAPZIMEOS, again, it represents an amazing potential cure. Again, a lot of that data now has been shown. We're looking at 3-year data. And then we would like to continue that in all of our efforts here. And I just think that PAPZIMEOS could not only represent a cure for those patients, but also spare payers from paying from costly debulking surgeries. Thank you.
All right. Appreciate, you're coming forward and your passion and helping to treat our members. So you said that there's a large cohort. I don't know what your words were exactly about number of people that are waiting for this therapy up at OHSU.
Yeah. From what I've been told, it's about 100 patients, with many that are severe, but many that potentially, and not only just from one provider, but from multiple providers. So there is a fairly large cohort, and that's, again, that's a broad estimate, but we do have we would like to treat quite a few patients. We understand the cost of the drug. We understand this kind of how everything's made, but we do have a lot of patients that are impacted by this disease.
And is there a bandwidth issue on behalf of OHSU for how quickly they could treat patients?
Not at all. That is my specialty. Is creating the operations for us to acquire and implement from every aspect of the medication use process. And so I personally have been working with Precigen, hence kind of why I'm here, and just ensuring that once we did get it approved from our gene therapy oversight committee, we could implement quickly. And so I'm ready to go. I think right now we're identifying the payer landscape and what this is going to look like and who we can and can't treat. But that is where we're at now, and we have the facilities, we have we have all the resources to treat these patients.
Great, thank you. I'm going to quit dominating the time. See if there's any other
Yeah.
questions from the staff, the reviewer, or the committee. All right, hearing none. Andrew, Doug, you're coming up. Did you have a question?
Well, obviously, one of the questions is around patient identification and the definition of recurrent, etc. I know there's a lot of enthusiasm for potential in the future and the outcomes, but if we approved the recommended prior authorization criteria now, it doesn't. Obviously, I think that the OHSU would be wanting to treat the more serious cases to begin with, offer that to them and in queue, and it doesn't preclude us from modifying and liberalizing our PA criteria as time goes on and if further evidence emerges. Is that correct?
That is correct. Yeah, we always try and review PA criteria, keep an eye on PAs that we're getting, any exceptions that are made through medical director, and incorporate those into the criteria and bring it back to this committee.
Thanks, sir.
Appreciate it, Doug. Any other questions for Andrew? All right,
Just
again,
to
Andrew.
call it out and
Yeah, Pat.
acknowledge that, it's sort of a normative approach for these criteria to use clinical trial inclusion criteria, especially when, we got like a phase 1/2 study being the sole source of evidence. So
Thanks, Pat.
Appreciate that observation. Any other questions or comments? Again, thank you for your time, Andrew. We'll put the recommendations back up for the committee.
Thank you all.
You betcha. Again, recommendation from the committee is to designate zopapentadine. It's unpronounceable for me, the non-perver on the PDL, and implement the PA criteria as to cover adults when the other RRP treatments have failed.
I
Discussion
move
or
for approval.
Thank you, Doug.
Do we have a second?
Second.
Thanks, Pat. All right, all those in favor?
Hi.
Opposed? Abstain? All right, thank you. And thank you, Andrew.
Okay. Moving on, draw your attention to page 145 in the packet. We have a new drug evaluation for Sohonos, and we'll turn it over to Dave.
Okay, thank you, Roger. So yeah, today we'll be evaluating palovarotene for the treatment of fibrodysplasia ossificans progressiva. It's a condition we'll refer to as FOP for the remainder of the presentation. Next slide, please. So for this evaluation of palovarotene, we'll look at efficacy and safety data, as well as any application to special populations in the treatment of FOP. Next slide. So FOP is a rare genetic disorder of abnormal bone growth in soft tissues. Eventually causes hardening and ossification in those regions. There's about 1 out of every 1.6 million newborns affected. It's caused by a random gain of function mutation in the ACVR1 gene. And it's associated with abnormal bone formation, painful flare-ups, and muscle damage. And since it's a progressive disease, patient mobility is increasingly hindered. So usually by age 30, wheelchair assistance and ongoing rehab is required just for them to perform daily tasks. Next slide, please. Yeah, so Pelavarotene, it's an orally bioavailable retinoic acid receptor, or RAR gamma agonist. It was FDA approved in 2023 for the treatment of heterotopic ossification due to FOP in females at least 8 years old and in males at least 10 years old. And it has fairly complex mechanism, but basically through the binding of RAR gamma, pelavarotene inhibits activity of bone morphogenetic proteins, so BMPs, and those decrease downstream signaling of pathways normally involved in chondrogenesis and osteocyte differentiation. Basically, the overall inhibition leads to reduced heterotopic or non-skeletal bone formation. All right, so pelavarotene efficacy, it was investigated in one open label, single arm phase 3 trial in patients with FOP. The primary endpoint was annualized change in new heterotopic ossification or HO volume in 9 body regions assessed by whole body CT scan at months 12, 24, 36, and overall. Post hoc analysis at 18 months demonstrated a statistically significant reduction in new HO formation in patients treated with pelavarotene compared to the untreated natural history study cohort. Let's look at safety. So overall safety is evaluated in 2 24-month periods. The mean duration of exposure to pelavarotene was 79 weeks. The most common adverse reactions in clinical trials were dry skin, arthralgia, pruritus, rash, and alopecia. About a third of the treated patients experienced a serious adverse event. That includes premature epiphyseal closure in patients under 14 years of age, for which there's an FDA boxed warning. There's also a boxed warning for teratogenicity, and thus it's contraindicated in pregnancy. There were some limitations. Study was open label, and they used historical control from a separate natural history trial. So the clinical benefit, therefore, is it's unclear as there's a lack of data on relevant clinical outcomes, things such as disease progression, function, symptom change, survival, or quality of life. And there were some post hoc adjustments to how the data was evaluated. So those were just a few of the limitations. We can look at the PA criteria. So yeah, it's pretty standard. I mean, first of all, we ask for a diagnosis, and 2, is it continuation or not? And the third, is it FDA, according to FDA label? Number 4, is there a confirmation by genetic testing? Number 5, it needs to be an FDA approved age. Number 6, was there a specialist for the disease involved? And then 7, we asked for a baseline assessment of skeletal maturity. So there's a few standard questions there. Next page. Number 8, we asked that the prescriber state the goal or goals of therapy. And then in number 9, we ask if the profile has been reviewed. So that is the drug profile, mainly to prevent drug interactions and toxicities, because there's a fair amount of them. In number 10, we ask if patients of reproductive age or not, and if yes. 11, we ask for a recent pregnancy evaluation. But then if no, they would have met criteria and they're approved for 12 months. The next slide is our renewal criteria. And so first of all, we want to know whether skeletal maturity has been reached for this patient. If yes, then they need to document all of those assessments. Otherwise, in number 3, we ask if, once again, reproductive age question, and then number 4 is the pregnancy monitoring. Number 5, we want to verify if there's adherence. And then in 6, making sure that there's no new meds that have been added that could be problematic. And then the last question is we ask that they document a positive response to therapy compared to the baseline assessment. So whatever they put as their initial baseline assessment, we ask that they reevaluate at the end of this period. So that is it for the PA criteria. The recommendations were to designate pelareorep as non-preferred on the PDL, and then implement PA criteria for pelareorep to ensure safe and appropriate use. So, any questions?
Good job, Dave. Questions from the committee for Dave? Hearing none, do we have a motion to approve in regards to the recommendations?
Motion to approve.
Thank you, Samara.
Second.
Thank you, Doug.
All right, all those in favor?
Aye.
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 Aye. Opposed? Abstain? All right, thank you.
Great. And for our final topic, draw your attention to page 162 in the packet. We have the topicals for inflammatory skin disease. And Deanna, take it away.
Thanks, Roger. If we could go to the next slide. Thanks, Sarah. So this is a drug class update and new drug evaluation. So we have talked about atopic dermatitis and plaque psoriasis in the context of the TIMS, but today we're going to be talking about it more, looking at the topical agents that are used. And then we have 2 new drugs that have been recently approved. The first is delgocitinib, which is FDA approved for the treatment of moderate to severe hand eczema in adults. And the second is sirolimus topical gel, which is FDA approved for treatment of facial fibroangiomas associated with TSC, or tuberous sclerosis complex. So if we could go to the next slide. This is an adaptation of a table that's in the PA criteria, which is on page 201 of the packet. I took out the topical steroid combination products and the vitamin D products that are used for atopic dermatitis and plaque psoriasis, but these are some of the newer agents that have been approved for the indications that you see over there on the right: atopic dermatitis, hand eczema, plaque psoriasis, and then we have one agent that's been approved for vitiligo. We could go to the next slide, please. So just a little bit of background. I use the terms atopic dermatitis or eczema interchangeably in this discussion. As you know, atopic dermatitis is a chronic skin disorder characterized by itching, recurrent lesions, and inflammation with a relapsing and remitting pattern. Going into a little bit more detail about hand eczema, chronic hand eczema persists for more than 3 months, or it recurs 2 or more times within a 12-month time frame. Chronic hand eczema is characterized by extremely itchy, painful, inflamed, dry, scaly patches of skin on the hands and wrist that can flake, crack, or bleed. And chronic hand eczema is often associated with occupations that involve frequent hand washing, exposure to chemicals, or working in wet environments, including healthcare workers, food handlers, dental technicians, hairdressers, cleaners, and florists. Other risk factors for hand development of hand eczema include having atopic dermatitis in childhood, having persistent or severe atopic dermatitis, living in cold or dry weather conditions, and decreased indoor humidity. The European Society of Contact Dermatitis guidance that was issued in 2021 recommends using protective gloves, hand washing in lukewarm, not hot water, switching from hand washing with soap to using alcohol disinfection when the hands are not visibly dirty, as alcohol can be less irritating than soap, and applying emollients to prevent the hand eczema. They also recommend that the initial treatment for moderate to severe eczema is short-term use of a topical corticosteroid or tacrolimus ointment. Patients that don't respond to this initial treatment may require systemic therapies, including oral corticosteroids, oral immunosuppressants, or phototherapies. The symptom scores that are used to specifically assess improvement in hand eczema are outlined in Table 2 in the packet. We could go to the next slide. The other diseases or conditions we'll be talking about is plaque psoriasis, which is a chronic immune-mediated inflammatory disorder of the skin, which affects 3% of the adult population in the United States, and about 1% of children are affected by psoriasis. According to the guidance issued by the American Academy of Dermatology and National Psoriasis Foundation, first-line topical agents to treat mild to moderate plaque psoriasis include the topical corticosteroids, the anthralin, the vitamin D analogs such as calcipotriol or calcitriol, retinoids, topical calcineurin inhibitors, or salicylic acid. The recently approved topical agent for treatment of plaque psoriasis, there's two agents, PDE4 inhibitor roflumilast and tapinarof. And then you may recall vitiligo is a chronic autoimmune disorder, and it's the most frequent cause of skin pigmentation worldwide, with an estimated prevalence of 1%. The British Association of Dermatologists guidance recommends high potency or very high potency topical corticosteroids or topical tacrolimus as a first-line treatment for vitiligo. The JAK inhibitor ruxolitinib is FDA approved for treatment of non-segmental vitiligo in patients that are aged 12 years and older. So if we could go to the next slide, a little bit of background about tuberous sclerosis complex. It's an inherited neurocutaneous disorder of cellular proliferation that produces benign tumors that affect the skin. And it arises due to mutations in either the TSC1 or TSC2 genes, which are responsible for overactivation of the mammalian target of rapamycin, or mTOR protein. So that gives rise to non-cancerous growths in multiple organs. The dermatologic features of TSC include hypopigmented macules, angiofibromas, shagreen patches, and fibrous forehead plaques. The angiofibromas typically develop over the central face and cheeks, and they may bleed, they may obstruct some of the facial orifices or cause disfigurement, and that can all lead to emotional distress. When not prominent, the skin lesions do not require treatment. However, they do need to be closely monitored so that if they are causing any pain, bleeding, functional impairment, or social problems, it can be addressed. Generally, they're treated by either surgically excising them, using cryotherapy, dermabrasion, laser treatments, or applying a topical mTOR inhibitor such as sirolimus. So the surgical and laser procedures may be performed several times to reduce the recurrence of the lesions, but they might be painful, and the angiofibromas may be resistant to topical treatment, and so they may benefit from laser therapy. Some clinicians have suggested that topical sirolimus may be effective as a pretreatment for larger angiofibromas, but due to the rarity of this condition, the evidence for the standard of care for treating the facial angiofibromas is limited, and no guidance has been published. All right, so we'll move into the systematic reviews. There were 3 systematic reviews published since we last reviewed this topic in 2022. The first was a 2024 Cochrane Systematic Review and Network Meta-Analysis. Usually we don't include network meta-analyses in our reviews, but since this was part of a Cochrane review, I included it. In this particular review, they looked at all the agents that are approved for managing eczema, and they specifically called out eczema as what they were looking at. And they found that potent and very potent topical corticosteroids, tacrolimus and ruxolitinib, were the most effective short-term treatments for improving patient-reported symptoms. That was based on 40 trials, all with low confidence of their in the evidence. And then clinician-reported signs, which were a little bit stronger evidence of reducing the eczema. The most common reactions were local application site reactions, and those were observed with tacrolimus and crisaborole, and least common with the topical corticosteroids. They also observed that skin thinning was not increased with short-term use of the topical corticosteroids, but if it was longer term, over 6 to 60 months, then they did see the skin thinning. The next systematic review on the next slide was a systematic review and another network meta-analysis that was the basis for the American Academy of Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology Joint Task Force guidance that was issued in 2023. Their review determined that the most effective agents for improving atopic dermatitis outcomes are pimecrolimus, tacrolimus, and moderate potency topical corticosteroids. Crisaborole was intermittently effective, but there was uncertain harm due to low quality evidence on adverse effects. And then high certainty evidence showed that the super high potency topical corticosteroids were the best at improving the severity of the atopic dermatitis, as well as tacrolimus and the high to moderate potency topical corticosteroids. The chart of the different potencies is listed on table 4 in the packet. And so those were all good at improving the itch severity. And then pimecrolimus was the best for improving sleep disturbance. And then the newer agent, delgocitinib, was the best at improving quality of life for eczema-related issues. The next systematic review looked at the incidence of cancer associated with topical calcineurin inhibitors, and that was part of the 2022 guidance update. And they found that the absolute risk of any cancer with the topical calcineurin inhibitors was not different from controls, and that was based on moderate certainty evidence, and that the use of either TCI had no association with cancer. So that's a little bit different because there had been a black box warning about the risk of cancer with these agents. If we go to the next slide. So there were, since our last review, there's 6 guidelines that have been published to guide treatment of mild to moderate atopic dermatitis, plaque psoriasis, and vitiligo. So the 2022 guidance that I mentioned for management of atopic dermatitis says that although using an emollient alone can help, almost all patients will need some sort of prescription therapy, either a topical corticosteroid, a calcineurin inhibitor, or the PDE4 inhibitor crisaborole. This particular group did not recommend ruxolitinib for AD because they determined that there was insufficient evidence to assess whether it reduces AD flares because the trials were short-term. So based on the nature of the available studies at that time, they did not recommend it. In contrast, the American Academy of Dermatology guidance does recommend ruxolitinib for management of mild to severe atopic dermatitis. And then they added 2 more recommendations in their most recent guidance supporting the use of tapinarof or roflumilast to manage mild to moderate AD symptoms. If we go to the next slide, we had 3 recommendations from Canada's Drug Agency. So in 2025, they did not recommend reimbursing ruxolitinib in Canadian patients, mostly because the published studies, although they did not show that the ruxolitinib led to a meaningful improvement in overall health-related quality of life. And they didn't have any data on how ruxolitinib compared to other agents used for vitiligo, such as the topical corticosteroids or tacrolimus. And they had similar recommendations for using ruxolitinib or reimbursing ruxolitinib in the Canadian population, and that was based on the fact that there was 2 clinical trials that showed that ruxolitinib improved the severity of atopic dermatitis, but there's no comparative trials to see how it compares with either the topical corticosteroids or calcineurin inhibitors, which is the population that you would be expected to receive ruxolitinib. In September of 2023, the Canadian Drug Agency did come out with some guidance about using roflumilast in patients with psoriasis, and they just recommend that they have an IGA score of at least 2 and in an area that's appropriate for topical treatment with an affected body surface area between 2 and 20%. And then they recommend that after 8 weeks, if the response hasn't been achieved, that the therapy be stopped. And they define a response to treatment as an IGA score of clear, or almost clear, or 0 or 1. So that's it on the guidelines. And now we'll move into the new indications and formulations. So there was a lot of new formulations of some of the drugs that were already on the market. So a new formulation of roflumilast came out just in October, 0.05%, and that's approved for pediatric patients with atopic dermatitis that are aged 2 to 5. And then in September of this year, ruxolitinib was approved for topical short-term and non-continuous chronic treatment of mild to moderate atopic dermatitis in patients that are aged 2 years and older. Earlier this year in May, roflumilast 0.3% topical foam received an expanded indication for use in psoriasis in patients that were aged 12. Before that, it was only approved for treatment of seborrheic dermatitis in patients that were 9 years of age and older. And then last year, roflumilast 0.15% cream received approval for treatment of atopic dermatitis in patients aged 6 years and older. Prior to that, it was approved for psoriasis. And then tapinarof received an expanded FDA-approved indication for topical treatment of atopic dermatitis in adults and children aged 2 years and older. And before that, it was only approved for treatment of psoriasis in adults. Now we'll move into our new drug reviews. So the first drug we'll talk about is delgocitinib, which is a JAK inhibitor. And it also has it also works on tyrosine kinase 2. So as I mentioned earlier, the FDA-approved indication is for treatment of moderate to severe chronic hand eczema in adults that have had a inadequate response to or for whom topical corticosteroids are not advisable. The evidence table is on page 185 if you want to take a look at that. The 2 clinical trials used the investigators' global assessment of chronic hand eczema. The other assessments are described on table 2 on page 168. So the IGA-CHE is a clinician assessment, and it just looks at the severity of the disease using a 5-point scale ranging from 0 to 4. And scoring is based on the intensity of the redness, the scaling, the hyperkeratosis, the vasculation, edema, and fissures. So the next slide is a summary of the 2 trials, Delta 1 and Delta 2, which were phase 3 trials, and they both supported the FDA approval of this drug. More women than men were enrolled in the study, which is typical of for chronic hand eczema. The exclusion criteria were active psoriasis, infection, active atopic dermatitis in regions besides the hands and feet. And so the major inclusion criteria was a score, an IGAC-HE score of 3 or 4, or moderate to severe hand eczema, and they had to have an inadequate response to using topical corticosteroids within a year of study enrollment. The study was conducted over 16 weeks, and in both studies, the delgocitinib was more effective than placebo in improving the IGA-CHE score to either clear or almost clear at week 16, along with a 2-step improvement from baseline. Draft recommendations from Canada's drug agency, they haven't been published yet. They're still under review, but they suggest that delgocitinib should be reimbursed for the treatment of moderate to severe chronic hand eczema in adults if topical corticosteroids are inadequate or not advisable. Only if patients meet the same criteria that were described in this study, so having an IGA-CHE score of 3 to 4 and not eligible for high-potency topical corticosteroids, and they recommend assessing their response at 12 weeks to make sure that there is improvement in the symptoms. We can go to the next slide. So the main limitations was this was a placebo-controlled trial. It would be more meaningful if we had a comparison to topical corticosteroids or calcineurin inhibitors to give us some idea for place in therapy. Although the patients did try topical corticosteroids, but we're not sure how it compares to the calcineurin inhibitors. Also, this was a short-term trial just conducted over 16 weeks. An open label extension trial was conducted over 36 weeks, and in this particular trial, 17% of patients stopped treatment due to either lack of efficacy or patient withdrawal from the extension trial. In terms of safety, the most frequently reported adverse events occurred in less than 1% of people, and not surprisingly, it included application site pain, paresthesia, maybe some itching, erythema, and bacterial skin infections. The manufacturer does recommend completing any necessary immunizations, including herpes zoster vaccinations prior to starting therapy with this drug. And then use with other JAK inhibitors or potent immunosuppressants is not recommended. It's not known if topical delgocitinib is associated with adverse reactions like the cardiovascular events or DVTs or malignancies that have been observed with the oral JAK inhibitors. At this time, delgocitinib does not carry the box warning that oral JAK inhibitors have for the risk of these serious adverse events. All right, next slide. We're going to start talking about sirolimus, or Hyfetor, which is the drug that's approved for treatment of angiofibromas. They're not sure what the mechanism of action is for treating, for improving the angiofibromas. The FDA-approved indication is topical treatment for facial angiofibromas associated with TSC in adults and pediatric patients aged 6 years and older. This drug, also known as rapamycin, has been available as an oral formulation since 1999. It's approved by the FDA as the oral form for prophylaxis of organ rejection. And topical sirolimus has been studied in a range of concentrations for the treatment of angiofibromas in TSC, and it's been prescribed or compounded off-label since 2006. If we could go to the next slide. So there's one study, it was a double-blind placebo-controlled randomized controlled trial. It was fairly small, given that this is a rare disease, 62 patients. It was conducted at 9 centers, all in Japan. So they were able to enroll 35 adults and 27 pediatric patients. There were more males in the sirolimus group compared to the placebo group. That was the only difference in the baseline demographics. And the mean age was 22 years of folks that were included in this trial. And so the major inclusion was to have a diagnosis of tuberous sclerosis complex with 3 or more facial angiofibromas, at least 2 millimeters or more in diameter. And the trial was conducted over 12 weeks. So the two primary endpoints were the percent of patients. Well, the one that the FDA looked at was the percent of patients with composite improvement in combined size and color of angiofibromas as documented in photographs. That's what the FDA was submitted to the FDA. And for this particular outcome, 60% of patients versus none in the placebo group had improvement. The other endpoint that the FDA looked at was the percent of patients that had improvement based on an in-person assessment by the clinician. And that was a little bit different. Only 23%. There was only 9 patients that had in-person assessments, but only 23% had improvement compared with 6% or 2 of the patients. This was considered not significant, but the p-values and confidence intervals were not reported. So the trial limitations, using that photographic technique to assess the improvement, it wasn't standardized in terms of lighting, background, or distance from the camera. And then they had 3 dermatologists that comprised an independent review committee that assessed the photographs, and they used a 6-point scale to assess the improvement. Unfortunately, the scale was not validated prior to use in the randomized control trial. And then the FDA pointed out that the final assessment score could be modified based upon consensus discussion of the blinded assessors. The rationale for conducting these discussions was not provided by the investigators, but the need to discuss and change the scores of several assessments during the trial raises concerns related to accuracy and inter-rater reliability of the rating instrument. And finally, as I mentioned earlier, all the trials were conducted in Japan, so the applicability to Oregon Medicaid patients is unclear. There was a 104-week open label safety trial, and in that particular trial, the most common adverse reactions associated with application of the drug were application site irritation, dry skin, acne, itching, eye irritation, redness, and then some different types of dermatitis, as well as photosensitivity reaction. I do want to point out that systemic exposure of drugs that are substrates or inhibitors of CYP3A could be increased with co-administration with sirolimus, and concomitant use of sirolimus with CYP3A4 inhibitors can increase the exposure to sirolimus and increases the risk of adverse reactions. The manufacturer has reported that live vaccines should not be administered while using this topical agent, as the vaccines may be less effective. And then finally, the drug is systemically absorbed after topical administration, and it may result in fetal exposure. So the manufacturer recommends that effective contraceptive methods are recommended for females of reproductive potential during treatment and for 12 weeks after completing the topical therapy. So next, we'll talk about changes to the PA criteria, which start on page 200. So the first was to revise Table 1, which is the list of FDA-approved ages and indications for topical drugs that are approved for inflammatory skin conditions. So we added the 2 new drugs, delgocitinib, as well as the sirolimus, and then also the new formulation for roflumilast. You can see there's quite a few different formulations of roflumilast now. There's different strengths of the cream and the foam, and their approved ages all vary as well. So that's all outlined in this table. And then on the next slide, we added a question about having renewal criteria. We didn't have renewal criteria before this, so we added this. And then question 4, we added documentation of the disease severity based either on the DLQI or BSA involvement. And then if we go to the next slide, we just added some examples of for the EPSDT assessment in question 5. And then question 6 is referring back to table 1 to make sure that the drug is being prescribed according to the FDA label and that it's for the appropriate age. And then in question 7, we added chronic hand eczema as another diagnosis. And then in question 9, we changed it to say, have they tried at least one topical corticosteroid or an additional nonsteroidal preferred agent? And then finally, in the last few questions, we start asking about the diagnosis of facial angiofibroma associated with TSC for the use of sirolimus. So if we could go to the next slide, all of those questions pertain to the sirolimus. So is it, can they document the functional impairment or the issues that are necessitating treatment with the topical agent? Is it prescribed by a dermatologist or a neurologist or a provider that has expertise in managing TSC and its complications? And then we added our typical childbearing questions that we use based on what the manufacturer has listed as a possible complication of topical treatment with this agent. And then on the next slide is the renewal criteria. So is it to renew therapy for plaque psoriasis, atopic dermatitis, chronic hand eczema, or non-segmental vitiligo? And then have the symptoms improved using any of these scores, either the EASI 50 or the Dermatology Life Quality Index, or at least a 2-point improvement on the investigator's global score. And then if it's for renewing the facial angiofibromas, we just need documentation from the provider that treatment has resulted in improvement in size and redness of the skin lesions. So the next slide is a summary of our recommendations, which are to revise the PA criteria, as I just described, to include the expanded indications for the ruxolitinib cream, foam, the roflumilast cream, the sirolimus gel, and the tapinarof cream. And then to maintain delgocitinib cream as non-preferred, and then makes sirolimus topical gel non-preferred on the PDL. And we'll look at drug costs in exec session. Are there any questions from the P&T committee about the PA criteria? If not, I think we have some public comment. Is that right, Roger?
You are correct, Deanna, as always. Any questions for Deanna? All right, hearing none. Crystal Injo, are you from Arcutis Biotherapeutics? Are you able to unmute your line?
Yes, I am. Thank you so much, Roger.
You're welcome. The floor is yours.
All right, thank you. My name is Crystal Ngo, and I'm the Director of Medical Values and Outcomes employed by Arcutis Biotherapeutics, speaking to Zoryve foam and cream. Thank you again to the committee for the overview of roflumilast or Zoryve. And as mentioned earlier, on May 2025, Zoryve 0.3% foam was recently approved for scalp and body plaque psoriasis in patients 12 years and up. Last month, Zoryve 0.05% cream was approved for the treatment, in November, was approved for the treatment of mild to moderate atopic dermatitis in patients 2 to 5 years of age. For Zoryve 0.3% foam, the pivotal Erector study demonstrated a statistically significant percentage of patients achieving scalp and body IGA success at week 8 when comparing Zoryve 0.3% foam to vehicle. 0.3% foam is well tolerated with low incidences of adverse events, and the foam is uniquely formulated to make application to the scalp and other hair-bearing areas easier. And patients with psoriasis affecting both the body and scalp may require several topical products to address different application considerations. And the foam is a single topical option for patients that's efficacious and well tolerated for the treatment of scalp and body psoriasis. Additionally, I would like to add that the foam is also the only topical product indicated for the use of the treatment of seborrheic dermatitis in patients 9 years and up. For Zoryve 0.05% cream, this was studied in the pivotal trial, the INTEGUMENT-PEDS, in patients 2 to 5 years of age. A statistically significant greater portion of patients achieved the primary endpoint of IGA success at week 4, and the 4-week endpoint was intentional to demonstrate the rapidity of response. The 0.05% cream was well tolerated, and the safety profile observed in the open label extension trial was generally consistent with the safety profile observed at week 4. Durable effectiveness was also observed in 56 weeks of treatment, where of the patients who achieved an IGA of 0 or clear, 30.2% were switched to twice weekly application, with the median duration of those maintaining disease control was about 238 weeks, or about 8 months. So overall, the foaming cream is a once daily steroid-free option with no label restrictions on the duration of use. And with that, we respectfully request Oregon Medicaid to have the Zoryve 0.3% foam and 0.05% cream to be added to the formulary as preferred, with a single step through a topical corticosteroid. And with that, I'd like to thank the committee for your time and consideration, and I will open it up for any questions the committee may have. Thank you.
Thank you, Crystal. Any questions for Crystal? All right, next we have Valerie Ng from Leo Pharma. Valerie, are you able to unmute your line?
I am. Can you hear me okay, Roger?
Loud and clear, and the floor is yours.
Awesome. Thank you. Well, good afternoon, everyone. I'm Valerie Ng, part of Medical Affairs at Leo Pharma. Hopefully, I'm able to share additional information today on Anzupco or delgocitinib, which is the first and only FDA-approved treatment for moderate to severe chronic hand eczema or CHE. And as Deanna, you mentioned, it is not the same as atopic dermatitis of the hand. So CHE is a complex inflammatory skin disease with a high burden on patients' lives, defined by this persistent and debilitating itch and pain. And by uniquely blocking all 4 members of that JAK family, Anzupco broadly targets that heterogeneous pathophysiology of the CHE disease, and it is different, right? It's got the overlapping subtypes, not the same as just atopic dermatitis of the hand alone. I wouldn't repeat what Deanna had already mentioned. The recommended dosage of Anzupco or delgocitinib is a thin layer applied twice daily to the affected areas, only on the hands and wrists. And in addition to the clinical trial results Deanna had already shared, the patients already also experienced rapid relief from their most burdensome symptoms, with a significant reduction in itch observed as early as day 1 and in pain by day 3. And additionally, long-term extension trial of those participants continuing on delgocitinib maintained this robust efficacy from the Delta 1 and 2, and also comparable safety profile out to that 1-year mark, demonstrating its value for chronic management. And in November, I would like to add too that the NICE UK also published its decision recommending the reimbursement of delgocitinib for patients with moderate to severe CHE. So in conclusion, delgocitinib represents a significant therapeutic advancement for a condition with a clear and high unmet need. And as the first FDA-approved treatment for moderate to severe chronic hand eczema without a boxed warning, it offers a novel mechanism that provides this rapid, this sustained relief from the debilitating symptoms of CHE, backed by a consistent safety profile. Therefore, would respectfully request the committee to have Anzupco or delgocitinib be made preferred on the PDL and have coverage criteria consistent with the FDA-approved label, providing access for Oregon Medicaid members suffering from moderate to severe CHE. With that, I'd be happy to answer any questions.
Great, Valerie. Appreciate it. Does the committee have any questions for Valerie? Okay. Again, thank you. And last we have Joe Cirincione from Insight. I hope I said your last name close to correctly. Are you able to unmute your line?
Yeah, can you hear me?
Hear you loud and clear.
All right, yeah, that was a great pronunciation. So as you did mention, my name is Joe Cirincione. I am a pharmacist and health outcomes liaison with Insight. Today I'm talking about Opzelura. And I do want to say that that was a very thorough review of the drug class updates. A lot of the things that you pointed out were what I was going to say, so I will make this brief. I know that within that drug class update, it was stated that a newer medicine, ruxolitinib, is not recommended by the American Academy of Allergy, Asthma, and Immunology and American College of Allergy, Asthma, and Immunology Joint Task Force, or Canada's drug agency for atopic dermatitis. These organizations say there's not enough evidence to determine if topical ruxolitinib decreases atopic dermatitis flares because it was only evaluated in short-term studies over 4 to 8 weeks. I do want to point out that since these guidelines were published, Opzelura has completed 3 phase 3 trials that were each 52 weeks. 2 of the studies were in patients 12 and older, and the third was in pediatric patients 2 to 11 years old. And then lastly, I do have 2 updates on Opzelura for atopic dermatitis specifically. As you did point out, so there was a new indication, or the indication age was decreased. On September 18th, the FDA approved Opzelura for the treatment of children aged 2 to 11 years old with mild to moderate atopic dermatitis. This is the same strength and dosing of Opzelura as used in adult patients. I do want to point out Opzelura is the only topical JAK inhibitor indicated for atopic dermatitis. And of note, as was mentioned in the review, Opzelura is still indicated for patients 12 and older for non-segmental vitiligo. And then lastly, I want to highlight new real-world evidence. A retrospective observational cohort study of treatment patterns after initiation of Opzelura was completed using 18-month US claims data. So this was 1,269 patients. The study showed that after starting Opzelura, patients used an average of 2.4 tubes of Opzelura in 18 months. 91% of biologic naive patients at baseline remained biologic free during the 18-month period after starting Opzelura, and close to 36% of biologic experienced patients at baseline did not continue their biologic therapy in months 13 through 18 after starting Opzelura. As for safety, the prescribing information for Opzelura includes box warnings for the risk of serious infections, mortality, malignancies, major adverse cardiovascular events, and thrombosis. Please refer to the prescribing information for the full indication statement and safety information. In conclusion, Incyte respectfully requests Opzelura be covered for patients with clinical criteria of a topical trial of a topical corticosteroid or topical calcineurin inhibitor. Thank you for your time, and I will answer any questions you may have.
Great. Thank you, Joe. Any questions from the committee? Okay, hearing none, we have the recommendations back on the screen in front of you. Recommendation to revise the PA criteria for the topical agents for inflammatory skin conditions to include those expanded indications, to maintain the deucitinib cream, and to make sirolimus topical gel non-preferred. And then we're also going to be reviewing costs in executive session to consider other changes. Any discussion or motion to approve?
Motion to approve.
Second.
Thank you,
Oh,
Samara.
second.
Thanks, Tim.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
All right, that concludes our open session. We're going to have to go off into exec session to discuss confidential information. I need to read a short announcement. No decisions will be made in exec, and we'll return to open session to make final recommendations. The P&T committee will now meet in executive session for the purpose of consideration of information and records that are exempt from disclosure by law. Executive sessions held pursuant to RS 192-6602F and ORS 414-3561 and 2, which allows the committee to meet in executive session to discuss confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or to comply with the requirements of ORS 414-353. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session except to state the general subject of the session as previously announced. No decision may be made in executive session, and at the end of the executive session, we'll return to the open session. We're going to pause the recording and move into the breakout room. All right, we're finishing up with exec session and returning to open session, so if you bear with us for a moment. We'll get everybody out of the breakout room, back in open session. If I can ask the committee to unmute your lines, just so you can be prepared to take recs, and I can do a head count to make sure we've got our quorum. Fantastic. And Tim, you're back as well, I'm assuming.
Yes.
All right. Perfect. Thank you. All right. I'm going to take these one at a time. The first class we have recommendations is for the antifungal class. We already had an open session recommendation for no changes to the PDL based on the clinical information. After review and executive session, the recommendations are to make terbinafine tablets preferred, to make miconazole solution and powder, cyclopyrex gel solution and cream, ketoconazole shampoo and cream, clotrimazole cream, clotrimazole betamethasone cream, and nystatin triamcinolone cream preferred, and miconazole 3-day suppository kits preferred. Do we have a recommendation to approve?
Motion to approve.
Thank you.
Second.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
Sorry, Stacey, I started to talk over the top. Thank you. For the next class, we have the epidermolysis bullosa new drug evaluation. The recommendation that we hadn't taken an open session before was about the PA criteria. So the recommendation is to implement the PA criteria that was proposed for the high-cost treatments for epidermolysis bullosa, including the birch terpenes, baramenogene, giboparvac, and the prademagene zemikeracel. And after review of costs and executive session, the recommendation is to make Zavaskin, Filusev, and Vyjuvek all non-preferred and continue to explore supplemental rebates and value-based agreements.
So moved.
Thank you, Doug.
Second.
All right, all those in favor?
Aye.
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 All right, opposed? Abstain? All right, thank you.
Okay. And for the Carbaglue, recommendation in open session was to make one product preferred, implement the proposed criteria. And now after review and executive session, the recommendation is to make Carbaglue dispersible tablets, the branded agent preferred, and the generic carglumic acid non-preferred. Do we have a motion?
So moved.
Thank you, Doug.
Is there a second?
Second.
Thank you. All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thank you.
For the Niemann-Pick Type C new drug evaluations, the recommendation after evaluation of cost and executive session is to make brand Zavesca tablets preferred. Do we have a motion?
Motion to approve.
Thanks, Russ.
Second.
Appreciate it, Pat.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
And to close it out, the topicals for inflammatory skin disease, the recommendation after review of cost and executive session is to make no changes to the PDL. Easy one to make a motion on. And do we have a taker?
So moved.
Second.
Thanks, Doug. Thanks, Samara.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you all.
And that concludes the December P&T, the 2025 P&T session. Appreciate everybody's incredibly important volunteers for this important work. Pat and Stacy, thank you again for throwing your hat in and being reappointed. And Kat Livingston, big shoes to fill. Love working with you. Very happy that you're sticking around and doing work with the HERC, but thank you so very much for all of your important volunteer hours with this committee and your input to make our program better.
Thank you so much.
Absolutely. All right, the next P&T meeting will be scheduled for February 5th in 2026. I hope everybody has a happy holidays. And again, thank you very much.
Thanks,
Good night.
everybody.
Bye for now. You bet.
Bye.
Happy holidays.